Good morning, everybody. Thank you so much, sir, for elaborating me in a short and sweet way. Today's my topic of discussion is how we can manage the patients who are critically ill in post-operative period. So let's come to this one case scenario. Is a 75 years old gentleman who is known case of diabetes, hypertension, ischemic heart disease with ejection fraction of the 40%, underwent esophagectomy and gastric pull-through operation. On the day 4 of post-operative period, patient had a sudden onset of chest pain, breathlessness, increased oxygen requirement, hypotension. So how we can approach this patient? Because the cause of chest pain, breathlessness and shock may be varies in this type of patient. It may be varies from simple pain to the pulmonary embolism. So it may be because of the pain, acute coronary syndrome, patient is a known case of hypertension, there might be a possibility of diastolic heart failure, anastomosis, leak is not uncommon in this type of patient, pneumonia, especially day 4 of worsening of the day 4 of the new onset of the shock, patient is a known case of diabetes, decay is also a possibility, and pulmonary edema might be a possible in this type of patient if there is a cumulative balance is more or fluid overload or pulmonary embolism. So let's come to the simple, which type of the patients we can admit in the critical care unit. So in the ASA, in the American Society of Anesthesiologists has told there is a grading of the anesthesia. So from the ASA grade 2 to ASA grade 5, where there are patients who have an underlying comorbidity like a diabetes, hypertension or COPD may be controlled or very poorly controlled. Patient who has a end-stage renal disease, patients who underwent end organ acute events, that is a MI, CVA or stenting in more than 3 months or less than 3 months, or patients who underwent life-saving emergency major surgery like aortic dissection of aortic aneurysm or the massive trauma, or patients who came with any surgery with the septic shock. And yes, brain dead patient who is posted for the organ retrieval is definitely a very critical patient to maintain that organ perfusion. So we are keeping the patient who are at major risk, we are considering as a major risk, who has a sepsis, who has a hemodynamic instability, and who have a high risk of the respiratory complications. So coming to the cardiac risk, there are 6 independent risk factors where the patients may, if this type of patient go into the major surgery, then there might be a non-cardiac or cardiac death might be a possible in this 6 risk factor we have to consider in the mind. If patient is underwent a high risk supramajor surgery, patient has a history of ischemic heart disease, patient has a history of the heart failure or cerebrovascular disease, or patient who is a diabetes on insulin therapy, or serum creatinine if it is more than 2, then if the 3 or more risk factor is there, then it is independent risk factor that this patient may have some cardiac risk in his surgical time. So how we can optimize these patients? So we need to do a vigilant cardiorespiratory monitoring. At the same time, we have to manage the analgesia that will again stimulate the sympathetic stimulation and further worsen the condition. Tissue perfusion we have to keep in the mind, especially patient is hemodynamically unstable. Neuromonitoring in a patient with the neurocritic who are post neurosurgery, and nutrition and prevention of the pulmonary complications and DVT, and don't forget to maintain the euglycemia in the post-operative period. So let's come back to the basics. What the JLV told in the 2005, we have to consider not only medical but also in the surgical patient the fast hug. That is the feeding, analgesia, sedation, thromboprophylaxis, head-up position, ulcer prophylaxis and glycemic control. So let's come to the first component. So in a post-operative period, if your gut is working, then please use it because it is a more physiological, less chances of the infection. So we have to target the calorie from 18 to 20 kilocalorie per kg per day. We can go up to beyond 30 kilocalorie per kg per day, or we can start the protein 1.5 to 2 gram predicted body weight per kg per day. But if your predicted time of the nutrition is up to 10 days, then you can consider partial parenteral nutrition in this type of patient. But if it is expected time of enteral feeding is to be more than 10 days, then we can consider a total parenteral nutrition in some type of patient, especially when the patient is posted for resection, anastomosis also. Coming to the analgesia, we can consider analgesia from the simpler, that is a N-acetyl, that is a paracetamol, to we can paracetamol to the opioids, and also we can consider some awake sedation, that is a dexmed in some type of patients, and also regional anesthesia is one of the best method to give a post-operative analgesia. You can consider a ropivacaine, bupivacaine. with or without opioids in this type of the patient. But by using an NSAIDs in a critically ill patient, be aware there is a risk of acute kidney injury and the bleeding risk. Coming to the sedation, especially when the postoperative patients who are put in the invasive ventilation, we can consider opioids like midazolam, fentanyl. We can go up to the dexmed if your expected time of weaning in next 24 hours. You can use by the infusion method, but be aware the range of how much sedation is to be kept, because over sedation will ultimately again leads to the increased mechanical ventilator days, increased ICU stay, and ultimately increase the risk of the infection. Coming to the thromboprophylaxis, we are seeing many patients who are just doing okay, and we just started ambulation in the day 5, day 6, and we got the code blue activation. That patient is suddenly died. So DVT kills. Yes, so prevention is better than cure in this type of patients. So look for each and every critically ill patients who are at a high risk of DVT. So there is a Wells criteria for the same, especially in the post-surgical patients who are patients undergoing a malignant surgery for the malignancy. Expected time of immobilization is more than 3 days. In this type of patients or each and every orthopedic surgeries, we have to consider DVT prophylaxis, and patient who is already before that on any anticoagulation, they are also at a high risk of the DVT. So we have to consider early ambulation is a mainstay of treatment, but if patient is a very high risk of bleeding, you have to consider either pneumatic pump or DVT stockings. If patient is not a high risk for the bleeding, then we can consider unfractionated heparin to the LMWH in a mild renal dysfunction. You can consider a fragmin in this case. And NOAC is not an uncommon drug now we are using in the postoperative patient, especially when patient is posted for the replacement orthopedic surgery. Coming to the head of position is a mainstay in a post-operative patients because it prevents the aspiration, prevent the atelectasis, increase the vital capacity, and also it is an important mainstay to prevent the ventilated associated pneumonia. So you have to consider a head-up position unless it is contraindicated in some type of patients. Ulcer prophylaxis, yes, surgery is a stress for the patient, so you must consider ulcer prophylaxis. And especially with a high, the H2 blocker versus PPI is still debatable, but you can consider a PPI in a very high risk of bleeding and a coagulopathy patient, who are at a high risk of the coagulopathy. Last but not the least, sugar control. So the glycemic control, we don't target intensive sugar control. We always target a 140 to 180 milligram per deciliter sugar control. That is a permissible sugar control, because some meta-analysis is done which is showing there is a decrease in mortality and morbidity in the patients who are considering a permissive sugar control. Now coming to the most important care is a pulmonary care in post-operative patients, because in each and most of the time of the patients who are going into the supramajor surgery, their FRC and vital capacity is decreased up to the 40 to 50%. So we have to keep in the mind that if there is a hypoxemia, there is a possibility of this reason. There might be atelectasis, upper airway obstruction, especially when in the first 4 hours. Because of the tongue fall, pulmonary edema may be cardiogenic or a non-cardiogenic. Pneumonia we have to keep in the mind. And yes, in the third or fourth post-operative day, if there is a new onset of pneumonia, then you have to consider there might be a chances of the hospital-acquired pneumonia. And pulmonary embolism also you have to keep in the mind. So how we can prevent all these things? So early ambulation, aggressive chest physiotherapy in any supramajor surgery, and CPAP in selected group of the patient to decrease the basal atelectasis. If the patient, especially morbidly obese patients or patients is already on the home BiPAP therapy. Coming to the fluid therapy, so there are two types of fluid what we have to consider in the postoperative period, that is a replacement fluid therapy and maintenance. Replacement is what is residual fluid deficit in the fluid intraoperative period, third space loss, and it's according to the ongoing what is GI or any other fluid loss. Maintenance we are giving mainly to balance the electrolytes and also to counteract the catabolism of the patients. So why it is important? Because of there is we are mostly entering into this major cavity, tissue disruption is occur, blood loss is occur, and there is a hemodynamic instability may or may not be occur, and if there is with infection, then you have to additionally consider a fluid with dynamic hemodynamic parameter that we are using, like 2D core IVC collapse, IVC guided fluid therapy. Maintenance fluid you can give at 1 to 1.5 ml per kg per hour. Choice of the fluid, Always the crystalloid is the choice of the fluid that we are using for all the things. Blood and blood products is to be considered, and dextrose as a maintenance fluid to counter the catabolism. So how we minimize the cardiac risk in a critically cardiac patients? First is right anesthesia technique, optimize fluid therapy in this type of patients, vigilant monitoring, optimum analgesia, maintains the electrolytes balance, and also start early antiplatelet and anti-failure treatment and LMWH in a critically ill cardiac patients.
2 minutes
left. Last but the not least, infection prevention is utmost important. So choose the perioperative antibiotic according to your hospital stewardship guideline. Follow the all bundle of infection in the pre-op, perioperative and post-operative period, that is Web, Corti, Klebsiella and SSI bundle. Timely recognize the new onset of sepsis and starting a treatment according to your antibiogram in your hospital, right? Because that is most important, because the 4th or 5th day, if there is a new infection, then there is a possibility that patient may acquire hospital-acquired infection. So coming to our case. So let's go to the X-ray of this case. Post-operative day 1, we are not seeing too much, just basal collection is there. But on the post-operative day 4, you can see there is a bowel loop that is coming on the right side of the thoracic cavity. So this is the culprit why this patient has an acute onset of the chest pain, breathlessness and shock because of the increased intrathoracic pressure. So yes, this patient underwent again redo surgery because there is the bowel loop and all the things because of hypertension, the bowel loop are migrated into the thoracic cavity, and after re-exploration the X-ray is showing like this. Ultimately, what we are doing for the patient who are very critically ill, but what is the outcome of the patient? Why the patients are dying? Which type of patients are dying? So there is a last study has been done which is showing the patients who are hemodynamic unstable, high ASA and Apache score and low GC scale, they are independent risk of the mortality, and patients who are taking for the emergency supramajor surgery, they are also at a risk of the death, independent risk for the death. So take home message is critically ill, high risk patients are kept in the ICU at least for 24 hours. Post-operative pain is the key factor for atelectasis. So in many patients, so please ensure analgesia adequately. Early ambulation is a mainstay for the prevention of the DVT, and on the other hand, you have to consider a DVT prophylaxis in a critically high risk patient who are at risk of the DVT. Chest physiotherapy and secretion toileting and head-up position is important for the post-operative pulmonary care. Optimize the fluid balance according to the dynamic hemodynamic parameters over and above the maintenance fluid. Use a strict infection control policy for each and every patient to prevent the hospital-acquired infection, and also last but not the least, psychological counseling in a terminally ill patient who are actually underwent a malignant surgery or a long surgery, or especially elderly patient, you must have to consider the psychological counseling. Thank you.
Good morning everyone, and thank you all chairperson for coming on time, and thank you Jain sir for introducing me. So without wasting time, we just directly go to the topic, point of care, lung ultrasound. So in 12 minutes of time, we'll just see the control and functions of the machines, what are the limitation of the USC machine, what are the techniques, normal findings of the lung ultrasound, and how you interpret the findings, and there are 4 to 5 cases on the practical cases. So before you scan, you know which probe you are using. Select your exam preset, abdominal, vascular, or this is probably lung, so this you have to set the exam preset to be of abdomen. Adjust your gain and adjust your depth. So before, which are the probes available? Over here, you can see this probe is a curvilinear probe. You see the hertz is 225. So lower the hertz, higher the penetration. And this is the linear probe. This is has a 6 to 13 hertz. So this is mainly for the, you can say about the A lines and to see the pneumothorax. And this is the cardiac probe, phase array probe. The hertz is 1 to 5 meters. So cardiac probe or the curvilinear probe can be used for the deeper tissue imagination for the lungs. Or you can, even if you want to use it for the fast protocol also, this can be used for the cardiac imagination also. And what are the images you get it from the linear probe? This is how you get it from the lung ultrasound. This is you can see over here is the A line, and what with the cardiac probe you can see this is an liver and this is an tissue. And what is the echogenicity on the ultrasound? You can see is a hypoechoic, this is an hypoechoic, and this is an anechoic. These are the kind of structure you see in the vessels. This is the kind of structure you see in the bones or the calcification, or this is kind of tissue you can see as a fat. Depth, generally depth will be mostly required for the tissue penetration according to the pathology. So probably to adjust the depth for the linear probe, we just adjust the depth to see the A lines and B lines, and we just see the depth to at least see the pathological things in the lungs from the linear probe or the linear probe. Why we needed lung ultrasound? Because physical examination is insufficient for the diagnosis. Bedside chest has a limited accuracy. Chest CT is not possible in each and every ICU patient, so ultrasound is easily available. It is non-invasive, portable, reduce the radiation exposure, and it's a low cost compared to the other therapy. What are the indications you go for the lung ultrasound in the ICU case or your indoor cases? For diagnostic purpose, for the intubation and confinement of the tube. So probably tube has gone on the right side on the right mainstem intubation. You can diagnose at the bedside, no need of X-ray. What are the DDs of acute dyspnea? You have a pulmonary embolism, you have pneumonia, you have ARDS, you have lung contusion. So these are the DDs you can at least have some idea after doing an ultrasound. What are the therapeutic indications for the lung ultrasound? You can do a diagnostic tapping, pleural tapping, and you can do a pleural biopsy, but generally is mainly for the tapping. And how you monitor the other disease, improvement or worsening of the pulmonary conditions, that is all the ARDS, or recruitment or de-recruitment after doing any maneuver. So suppose you are doing recruitment maneuver, you want to see the improvement in the typical lung zone. So that also you can do it at the bedside by the lung ultrasound. And also there are some protocols we just touch about: blue protocol, false protocol, EFAS protocol. What are the limitations? It can only detect the pathology that reaches the lung periphery, or you can just around 6 centimeters, not more than that. There are technical challenges also. You need to have a good images. Those who are obese, so we cannot have good images. And this also depends on the operator's skill. So it is not that once you start doing it, first you don't like the ultrasound images that you can get it when you started first time using the ultrasound, and then you're getting used to it. Then you love to use this kind of machine and you want to diagnose the things without the help of a CT scan. So there are 6 zones they are divided. First is the anterior superior zone and anterior inferior zone as the anterior side. These are the lateral side, 3rd and 4th, lateral superior, lateral inferior, and 5th and 6th is the posterior superior and posterior inferior zone. What are the views? Generally what we do, mainly we focusing on the longitudinal view for this typical A lines and B lines, and the transverse view, that is only for the lines if we are inserting the IJVs so that is not mainly of the use for the lung ultrasound. What are the A lines? A lines are basically just the reverberation artifact of the pleural line. So this is air. Air is very bad penetration for the ultrasound waves. So these are the lines. What we have seen here is basically just the reverberation artifact of the pleural lines. So A is for the air-filled lungs. So that is just simple thing. How you just want to see the one line. A is the air-filled lung. These are the normal lungs you can see on the linear probe. These are the A lines. And when you do a M mode at this level, so suppose you have freeze the screen over here and you put the M mode on the machine, and this is what you can solve is a seashore sign on the M mode. What is the B lines? These are arising from the pleural lines, and these are the typically well-defined laser-like lines that you can see coming from the pleural line. These are the vertical lines. A lines are the horizontal lines. There's a difference between A lines and B lines. These are the hyperechoic lines, long spreading out without fading to the edge of the screen. If that fades on the screen, that is called a Z line. This is not a B line. So suppose you have this line just fades over here, not coming fully to the screen. That is called the Z lines, and this moves with the lung sliding. That is the characteristic of the B lines. How just the B lines patterns are in a tissue and in disease pattern? It is if you diffuse B lines, you have a pulmonary edema. If you have pulmonary fibrosis, or focal B lines is pneumonia, ARDS, contusion, and hemorrhage. These are the B lines. These are the typical you can see in the edematous septal thickening, or when you have ground glass less than 3 mm distance, and you see multiple B lines. This is all the things you can see onto ARDS. So that's here you can see. This is the topical conso. This is, you can see a conso, and this is a typical hepatization of the, just like a liver thing you see in the lung. That's like a hepatization of the lung. This is the pleural effusion. So you can see a cord sign over here, rib shadows, and to diagnose the tapping, you would at least require 1.5 to 2 mm, 15 mm to 20 mm distance to have a diagnostic of the therapeutic tap. Or you can do M mode, and you can see there's a PLAPS index. You can just do it from this PLAPS, counting with the PLAPS index, and with that you can have a amount of the pleural effusion. Pneumothorax, you have a typical anterior abdominal lung sliding. Absence of lung sliding and presence of A line is the confirmation for the pneumothorax at the bedside. And this is a lung point where you can just partially diagnose if patient is having partial pneumothorax, not a complete pneumothorax. This is just a video. I'll show you the lung sliding. This is the normal lung sliding. As you can see, this is the normal thing. So whenever you put any patient in a normal lung, you see this kind of things. But this is the lung sliding with the seesaw sign. So this you have see, this is a typical skin to the ribs, and this is the beyond the ribs level. And then this is the second video is of the lung point. So here you can see here. So this is not moving, this is moving. So this, to find this kind of image is very rare, partial pneumothorax. But having said that, yes, it is just the level of the pneumothorax. Up to this level, patient might have a pneumothorax. But this is not commonly we see. So diagnose, how you diagnose PE with the A profile, patients of A lines with the lung sliding is present. That's how you diagnose even pulmonary embolism also. E-FAST protocol, they have included this right anterior longitudinal chest view and left anterior longitudinal chest view in the E-FAST protocol for the ER examination for the patient in the ER. What are the blue protocols? Blue protocols are for the diagnosis, just briefly going through the pulmonary edema, lung sliding present with the B line. You can just consider pulmonary edema, depends on the history, and the pneumothorax. You have an absence of lung sliding and you have a line, so you can just consider a pneumothorax, but you need to have a lung point or you need to have an X-ray for to diagnose the pneumothorax at the bedside. And false protocol, it is just to guide you regarding the how to give, how much amount of fluid you want to give or how you want to treat. So you need a echo and a lung ultrasound to diagnose all this shock, obstetric shock, cardiac shock, and the septic shock. So now we'll go into the first, quickly to the 4 to 5 cases. Just this is the question: all of the following can be seen in the lung ultrasound in pneumothorax except anyone? Lung sliding, yes. So lung sliding is absent in the pneumothorax. So all you can see a barcode sign, lung point, yes, you can see in the partial pneumothorax, and definitely, as I told you, absence of lung sliding with the presence of A lines is to consider a pneumothorax when you are considering. So second patient, Mr. A developed sudden hypoxia after 6 hours of prone positioning for the severe COVID ARDS. I just go through the video. Just wait, I will tell you when it is. Now you just consider what will be the. You have to just see this side. This is the M mode. Now there is a changes. Anyone? After seeing X-ray, definitely. But before having the, suppose if we have X-ray after 1 hour. So this was the patient, we did a prone positioning and then he developed pneumothorax without any P-plats was normal, but that might be a leak, and this has turned out to be a right-sided tension pneumothorax, and we have to put in 2 ICD for this. Now comes the Mr. B, a patient B transferred to our hospital with a diagnosis of type 2 respiratory failure with morbid BMI 45 with the bipolar disorder, and this was the initial X-ray at our ER. We don't know what will be this. There was no any, as the only history is patient having type 2 respiratory failure. So what could be the possibility on this X-ray? Or just I go through the lung ultrasound. So that can be a effusion, that can be a malignancy, that can be a collapse. So after looking at then lung ultrasound, any comments? It's a lung collapse. It's a recent patient we have in our ICU. The patient having lung collapse. We didn't want to go. CT scan has to be done, but because the patient is so obese and it is not possible to move around 150 kg guy to CT scan and to have any kind of complication during transfer. So we diagnosed lung collapse. We directly went ahead with the bronchoscopy and we removed the mucous fluid. That's the beauty of the lung ultrasound. You can avoid the number of CT scan to be done for the patient. This is the lung pulse. That is just like a cardiac pulse you can see on the ultrasound probe. So this is what you see over here. So this image is for the right mainstem intubation. So here you can see the typical, not a seesaw sign, typical lung pulse, but a multiple level. You can see the pulsatile thing, like you see the cardiac pulse at the lung probe. So this is what the lung point looks like on the M mode. And so the limitations of the ultrasound. So after seeing this X-ray, OPD patient, not an hypoxic, complaint of right-sided chest pain. What do you want to do first? Yes, HRCT, why? Yes, so this is the, this is a pneumothorax, it could be bulla also, loculated pneumothorax, we don't know. So here the USG might be not an ideal thing to at least to go for the first. Yes, USG you can do it, but when you have this kind of X-ray, definitely you can go for, you have to go for HRCT thorax to diagnose the thing, whether it is bully or localized pneumothorax. And I would rather say avoid ICD in this kind of patient until unless it's a stent with pneumothorax. And now the last question. What will be your immediate next step after seeing this X-ray? You want to go for USG, CCD thorax, ICD or pleural tapping? How many of you ICD? Okay, fine. Anyone? So this is basically a left diaphragm palsy due to the previous operating site, and that has led to a stomach inside the left lung. So definitely you need to go for CECT thorax. This can be a misleading for the hydropneumothorax. So just take home message, USG can be a good guide between X-ray and the CT scan, and with the use of USG, also you can reduce the number of CT scans to be done for the patient. So thank you everyone.
As we all are aware, last 2-3 years in COVID times, certain specialty has come into limelight, like pulmonary medicine, critical care medicine. In the same way, certain respiratory support system devices has come into limelight. One of that is relatively new on the board. It's a baby, maybe 10-15 year old. So let's discuss on high flow nasal cannula in critical care in general. Let's start with a case. She is a 72-year-old female, COPD on inhaled bronchodilators, presented with exacerbation of COPD symptoms like fever, dyspnea and cough, required NIV followed by ventilator support, and then later on after 5 days she was extubated and put on elective NIV according to the extubation guideline in COPD patients. So she was maintaining PCO2 of 52 to 55 with normal pH and minimal oxygen support. 48 hours post-extubation, she was a bit restless, dyspneic, not accepting BiPAP support. So what are the options available to support her in this case? Of course, this might trigger you to thought of HFNC because this is lecture based on it. But let's think it logically. Because it is hypercapnic respiratory failure, would you go for NIV as a best option with some sedation? Option 2. Will give trial of O2 by nasal prong to target SpO2 of 90 in COPD patient, or will you go for HFNC trial with high flow of 50 to 60 liter per minute, and because it is better tolerated, and or you will go for directly intubation as patient is not cooperative on BiPAP. Anyway, this is not voting, but we'll discuss how to answer it in the later part of presentation. So coming to the history of high flow nasal cannula, it was introduced in early 2000s to manage apnea in premature neonates, but it has established now role in pediatric bronchiolitis. Probably it gained attention from the landmark trial, Florali trial by Reva Group in 2015 June, published article in NEJM. But popularity of course has increased during COVID times due to ease of application, better tolerated by patient, better relief of dyspnea, improvement in hypoxia. From mild to even severe category it has been tried. And ultimately its use in out of ICU also. So some part of physiology we'll discuss here. What is normal inspiratory flow in a adult human? So anybody can? What is normal inspiratory flow in normal adult? That is in the range of 15 to 30 liter per minute, right? But in respiratory distress like mild ARDS, it goes above 30-60 liter per minute. So what conventional oxygen therapy gives? It gives oxygen at the rate of 5 to 10 liter per minute. So there will be significant entrainment because of the high respiratory drive. There is significant entrainment of atmospheric air that will prevent one from getting predictable and high FiO2 on conventional oxygen therapy. So that is limitation of plain mask or nasal cannula, which gives up to, from 24 to 50% of FiO2. At the max, with what you can see on the left side of figure is a Venturi mask, which gives high flow oxygen at a reasonably predictable FiO2. But the highest FiO2 is 60%. Again, the drive will be relieved by high FiO2, but at the same time, there will be issue with humidification in Venturi mask. So that will again affect the work of breathing and the function of the mucociliary system because of the dryness. On the right side of the figure, you can see it's a BiPAP mask. There are problem with BiPAP is intolerance. High pressurized flow will go into the patient, and there is a lot of desynchrony discomfort with BiPAP, as you all are aware of. And so there is difficulty in tolerability. There is claustrophobia feeling, and difficult to food and communicate with such group of patients. So what is unique to HFNC? As one of the benefit you can see on this right side of figure that upper airway, that is nasopharynx, will be, because of high flow, the anatomical dead space, CO2 is washed out in upper airway, right? So it has 2-3 peculiar thing, physiological benefit, clinical benefit. Because of high flow, it will wash out CO2. So the anatomical dead space is reduced. So there is some increase in diameter of, because of the flow and pressure effect, increase in diameter of upper airway, that will reduce work of breathing. The patients, because of high flow, it will match with patient's need. So there will be relief in dyspnea, and you will be able to provide fixed and predictable FiO2. And because of some PEEP effect, it will recruit the lung better and will give better oxygenation. Heated and humidified air with HFNC will reduce work of breathing and energy required for metabolic work of conditioning of gases. It will improve patient's comfort and mucociliary clearance. The interface, as compared to NIV, it is definitely less claustrophobic, more skin friendly, and better communication and food will be possible. This is typical HFNC device with a component of source of pressurized air and oxygen, air-oxygen blender, heated humidifier to condition the gases, and water reservoir with heated non-condensing inspiratory circuit, which is very important, and silicone nasal cannula as an interface. So this is typical device by what many of us might be using by Fisher and Peckel. So what are important practical recommendations? The prong has to be should not be occluding the nostrils completely. It should be 50% of diameter of nasal orifice. Water reservoir should be at the higher level as possible, and weaning, you can do weaning by a reduction in FiO2 or reduction in the flow gradually. So what are the indication of the HFNC? These are in general probable and possible indications, but most important is hypoxemic respiratory failure in immunocompetent or immunocompromised patient. Other indication like preventing reintubation in high risk medical cases, high risk post CABG or thoracic surgery cases are not well proven. Again, there are indications for apneic oxygen during intubation period and during bronchoscopy. So let's discuss this landmark trial, Florali trial, which was published in NEGM 2015. This trial include 310 patients. Majority patients were pneumonia. It was done in non-hypercapnic acute hypoxemic respiratory failure group of patients. They have compared HFNC compared to conventional oxygen therapy and NIV, but that did not result in significant difference in intubation rate. Though surprisingly, it improved mortality at 90 days, right, for unknown reason, but it did not reduce intubation rate. The power to reduce the intubation rate was found to be less in this case, and in subgroup analysis, post-hoc analysis, they found that in PF ratio less than 200, the intubation rate was reduced. So this was the landmark, one of the landmark trial. About the indication, ESIS-CIM, European Society of Intensive Care Medicine, has come up with guideline in 2020. The panel group, the expert panel group, has given few recommendations. Most important is about comparison of HFNC compared to conventional oxygen therapy. They straight away given the preference with strong recommendation with moderate certainty to give preference HFNC above high flow above conventional oxygen therapy. What they found, though there are multiple trials which showed that HFNC should be used as a rescue therapy. There have been trials which include NIV intermittent with HFNC, but they clearly found there is significant reduction in rate of intubation, there is improvement in dyspnea, respiratory rate, and oxygenation. So this was the recommendation. In medical patients who are at high risk post-extubation, they have electively preferred HFNC over nasal cannula O2 or conventional oxygen therapy. Who are at high risk? Those who are having age more than 65, Apache score more than 12, those having 2 comorbidities, and those with COPD and heart failure as a primary diagnosis, those who are unable to clear their secretion, they are high risk medical group of patients. They have recommended HFNC compared to conventional oxygen post-extubation in this group of patients. Those who are normally extubated to NIV, they have suggested to continue on NIV. What about the peri-intubation and about apneic oxygenation during? They did not come up with any clear-cut recommendation, and they did not favor HFNC over conventional oxygen therapy, because they found in operative patients, physiological normal patients, they found improvement in oxygenation, but in critically ill patients who are sick with some organ failure, they did not found any improvement in significant desaturation episode, that is less than 80%, and there is no difference in catastrophic event during this procedure compared to conventional oxygen therapy. In high-risk cardiac or CABG or thoracic surgery patient, they have recommended HFNC over conventional oxygen therapy. Those who are obese and who are high risk, those who are preoperatively cardiopulmonary point of view compromised, they have recommended it in this group of patients to give HFNC priority over conventional oxygen. So these are the indications according to this guideline. One good article if you want to review here. So what are the drawbacks and hazards of HFNC? Only possibility, it may delay intubation with adverse outcome. Those with HFNC failure, they are early, that is less than 48 hours, and late, who are more than 48 hours. Intubation following early failure has been associated with lower mortality compared to delayed intubation. So what are the early indicators of HFNO failure? Persistence of tachypnea more than 30, thoracoabdominal dysynchrony 30 minutes after the initiation of HFNC. Those who are having shock or presence of non-pulmonary organ failure has been associated with HFNC failure. There are index which has been developed to identify patient who will need ventilator support later on. Just last slide. So drawbacks are like mucosal irritation, discomfort, smell, bleeding from nose. They all are acceptable or manageable compared to benefit. So key point, it's a heated, high flow, non-invasive respiratory support system which is patient and even user friendly for nursing staff. Burden is much less. It helps to improve dyspnea, oxygenation, work of breathing, to reduce the need for intubation. In hypoxemic respiratory failure, whether immunocompetent or compromised. But though it has limited evidence-based medication, in high-risk group of medical or surgical patient, it can be very good option straight away compared to conventional oxygen, and it should not delay the intubation. And identify non-responder early in the phase of HFNC support. Thank you.
So let's talk about the RV failure. Can you extrapolate the RV failure from any condition? That's a different issue altogether. So I will limit my talk for the RV failure for the people who had a pre-existing pulmonary hypertension. I don't have anything to disclose. So we'll go for this one case, but I would like you to pay attention to the right upper corner where all the vitals are mentioned. So this is a 50-year-old female, has a history of shortness of breath, functional class 2 or 3, has a history of scleroderma and scleroderma associated PAH, pulmonary arterial hypertension, or a group 1 pulmonary hypertension. For scleroderma, she was on azathioprine. For the pulmonary hypertension, she was on ambrisentan and tadalafil for the last 4 months. So recently started PH treatment. Baseline functional class 2 or 3 symptoms, presented with now high-grade fever, cough with expectoration, and right-sided pleuritic chest pain. So whenever you see this triad, the fever, cough with expectoration, and the pleuritic chest pain, definitely a pneumonia picture comes to your mind. So the pre-existing or the pre-test probability of pneumonia is very high, which you I think can see on the X-ray here. These were the initial vitals. The heart rate is 110, blood pressure is 80/60, oxygen saturation is 89% on a room air, and the respiratory rate is 25, temperature is 101 degree Fahrenheit. So obviously patient was thought to have a sepsis with the pneumonia, so 2 liters of IV fluids were given, antibiotics were started. Still the patient was hypotensive, so the IV norepinephrine and IV vasopressin were started. So what are the goals of the medical therapy? What we want to do in such a patient? Anybody can develop pneumonia, anybody can develop septic shock, right? So the most important part for any patient, whether they have right ventricular failure or not, is obviously the treat the cause. How the treat the cause is different for this group of the patients, or what can make this PAH worsening. So of course the patient can have a PAH worsening due to a new etiology. For example, sepsis is one of the most common, or motor vehicle accident or a fall. Normally we ask young women who has a pulmonary arterial hypertension not to get pregnant, but that actually issue is raising again and again, and a lot of women now do get pregnant. So pregnancy certainly will worsen the pulmonary arterial hypertension, or if they are non-compliant with their medication, they have a further problem. So treat the cause accordingly. So on our patient, on a day one, once the patient has the IV fluid and the norepinephrine was started, next day the patient developed AFib with right ventricular rapid ventricular rate, with a heart rate now varying between 100 to 130. So heart rate is 110, AFib, blood pressure now slightly improved, 100/70, oxygen saturation improved after the oxygen therapy, respiration is still high, temperature is coming down. What will be the next best intervention? Should we consider metoprolol? Should we consider diltiazem? Should we consider stop norepinephrine or stop vasopressin? Some of these answers are definitely you can do any one of those things. In the area of a pulmonary arterial hypertension, there is a very low amount of evidences, unfortunately. But what will you do? I think I will probably stop the norepinephrine. That was probably I will stop the norepinephrine, and I will tell you why. Now the patient's blood pressure is better, and the norepinephrine in the septic shock patient is responsible for a lot of tachyarrhythmias. Calcium channel blockers and the beta blockers are actually partially contraindicated. I won't say that is absolutely a wrong answer. They are partially contraindicated because of the significant problem to the right-sided failure. Remember, the beta blockers will cause the negative inotropic and chronotropic action. So the negative inotropic action is significantly problematic for a right ventricle compared to left ventricle. So when right ventricle is failing, probably it's a better idea to avoid the beta blocker and the calcium channel blocker. So the second principle is improve the surrounding environment. And what we meant by surrounding environment, so treat manage the arrhythmias. Arrhythmias are always a precipitating factor for the heart failure, whether it's a right or left, it's always a problem. So we always say that in atrial fibrillation we lose the kick, right? The atrial kick is responsible for approximately 25% of the cardiac output. In a patient who has RV failure, actually 50% of the cardiac output is responsible by the atrial kick. So the atrial kick is a very important component for the RV failure, and the arrhythmia should be prevented or should be treated. If the patient is on a ventilator, then remember what you want to do is decrease the overall ventilator pressure. Higher positive airway pressure, either by CPAP or the BiPAP or the ventilator, is very good for the left ventricle. Remember, left ventricular afterload, it goes down by the positive airway pressure. Preload goes down by both the right ventricular and left ventricular. Preload will go down. But for right ventricle, when you increase the pressure, the afterload is increased. It will directly cause a pulmonary vasoconstriction, and the afterload is the amount of a pressure the ventricle has to generate to eject the blood, right? That's afterload. So the afterload will significantly be increased with a positive airway pressure. So those people, say for example, if they do not require very high PEEP, we tend to go the PEEP even lower than 5. Normally we try to keep the PEEP 5, but in those kind of patients we can actually keep the PEEP low. If they need it, they need it. I mean, there is no question, but try to avoid the higher volumes, try to avoid the higher pressure. Finally maintain a good metabolic profile, and this was a very interesting part. Like you can see this one in a metabolic profile, acidemia and hypoxemia has a significant impact on the pulmonary vasoconstriction. So in this study, what they found when the pH, for example, here, if I'm trying to have my cursor, okay, here. So when the pH is good, the 7.40, and the patient has a hypoxia, the pulmonary vasoconstriction or the increased PVR is not significant. But when the patient is acidotic and now become hypoxic, so look at the PaO2. So PaO2 goes below 50, there is an exponential rise in a pulmonary vasoconstriction, and lower the pH, more and more increase in the pulmonary vasoconstriction. So try to kind of manage the pH, and because the pulmonary vasoconstriction will increase, right ventricular failure will worsen. So always want to treat the acidemia and the hypoxemia. For a same patient on a second day or third day, once you stop the norepinephrine, the AFib was converted to sinus rhythm, the vasopressors are stopped altogether, blood pressure is very well controlled, lactic acid is normalized. So the septic shock part, I think, is improving on a day or 2 or 3, which typically happens if you have a right antibiotics on board. Patient now requires 50% high flow oxygen to maintain the SpO2 of 90 to 94. So hypoxemia did get worse. And these are the now vitals. The heart rate is 90, blood pressure is good, the saturation is 94, but the patient required a 50% high flow. Vipul just mentioned about the high flow. Temperature is still around the 100, and now you see this X-ray. So now what will be the next best action? Will you give IV furosemide? Will you do IV renal dose dopamine or IV vasopressin? I think the furosemide. And remember, the 85 to 90 times out of 100 in a patient who has a pre-existing pulmonary hypertension, the furosemide is probably the correct choice. Diuresis works. I think that's a golden principle. If you don't know anything, diuretics usually works. So patient, I think the IV furosemide was given. What is the reason behind that? Because we want to optimize the RV function. So the fluid management is very important. Even a half a liter of a volume in a patient who has RV failure will create a catastrophic problem. So fluid is to be treated like any other medication. Fluid is not safe. People can drown because of the fluid, and RV is very sensitive. Now, why does that happen? Because if you have an increased RV overload, we know that the septum, the interventricular septum between RV and LV will move towards the LV. So now LV end diastolic pressure will go up, LA pressure will go up, people will have more pulmonary edema, and people will have more hypoxia. When you actually diurese the people, the septum moves again towards the right side. So now LV is improved, LV preload is improved, LV cardiac output is improved, the blood pressure will improve. This is known as a interventricular dependence, because LV and RV both work in a synchronous fashion. We always say, oh, RV, it's a pulmonologist problem, LV, it's a cardiologist problem. It's not like that. The body works in a synchronous fashion, but this is a reason why you want to improve the fluid management. RV muscle function. So the volume management is a one part. The second part is a pressure management. And this is a picture I will show you whenever we talk about RV muscle perfusion. So the decreased supply, and this is very interesting part. This was a picture, or this was a study done long time ago in the basic science. So this is the aortic pressure. So this is your normal systolic pressure, normal diastolic pressure in the aorta. This is a left coronary perfusion. So the left coronary perfusion, we know that the coronaries are filled during diastole, and then the left coronary perfusion is like this. The right coronary flow, so this is whenever the aortic pressure goes down, the right-sided coronary flow goes significantly down compared to left side. So again, the right ventricle is very sensitive to the pressure. Right ventricle is very sensitive to the coronary blood flow. Coronary blood flow exponentially goes down when the systemic blood pressure goes down, much more compared to the left coronary. And second, there is a significant increased demand. The workload of RV can be calculated by stroke volume times the pressure, right? The stroke volume is a going flow forward, and a more pressure in the pulmonary artery pressure. So PSP is the pulmonary artery pressure. So normally, for example, your stroke volume is 60 ml, and your normal pulmonary artery pressure, upper limit of normal, is 20. So the total workload is 1200 units. Now in patient who has a RV failure, say for example stroke volume is reduced and PASP, the pulmonary artery pressure, is increased. So RV workload, for example, this is now 60 to 30, and then this is 20 to 80, the workload is 2400 units. So it's a like 200% or 300% increase in an RV workload, coronary blood flow is going down, RV will 100% crash. So very important part, the RV is different than the LV and we always want to manage the RV properly. So on a day 5, now patient has a normal sinus rhythm, heart rate is 90 to 110, WBC count is normalized. The patient has a 2.5 to 3 liter negative balance, patient's wean from the high flow, so all good stories. The pulse ox is now 94%. Now again the blood pressure started to drop from 120 to 100, 80 or 90 and 50 to 60 diastolic. Lactic acid is now increased. So this is a very important part and I have an important message here. 2D echo shows now worsening of RV dysfunction. And what might be the reason you guys are thinking? Embolism possible, yeah, of course, but everything else is getting better. The heart rate is getting better. Probably the patient was on those pulmonary arterial vasodilator medications and now we stopped it because initially the blood pressure was so low. So for the patient was on sildenafil and ambrisentan and then probably those medications are stopped. And that's why I think now the pulmonary hypertension worsened, the blood pressure is gone down. So now what can you do? Will you give IV epinephrine, IV dopamine, IV dobutamine or IV milrinone? IV milrinone? I think that probably will be a correct choice and I will tell you why IV milrinone. So you now want to improve the RV contractility. Several agents can improve the RV contractility. Whenever, as I said, that when the blood pressure goes down, the patient has a higher mortality. This was another basic science study back in 1980s. So for example, if a coronary driving pressure is 65 in a normal population, and if you check a lactate or a pyruvate, which is a sign of a metabolism from the coronary blood flow in the coronary veins, this was 17.6. These are normal numbers. Whenever the patient has a RV failure, the coronary driving pressure has been significantly reduced, as I was showing you in the previous slide also, and now the pyruvate or lactate gone up. And if you actually give them a phenylephrine or any vasopressor, as a matter of fact, sure, thank you. And then the RV coronary, the right coronary pressure is increased, the lactic acid or the pyruvate has gone down. So this was a study done in a dog, and this is one of the landmark study people quote always in the RV contractility and the RV pressure comes into the picture. As I mentioned, there are several agents, but the dobutamine or dopamine, and milrinone are more preferable in general. One of the study, and again, there is no right or wrong answer. One of the studies showed that the milrinone was better to improve cardiac index, and the milrinone has a more less increment in the mean pulmonary artery pressure. So the cardiac output was improved and the pressure was reduced by the milrinone. So the milrinone, I think, is a preferable choice. A subset of the patient who has even the pulmonary vascular resistance more than 2.5 Woods unit, like our patient, also had a similar situation that the vascular resistance was reduced by the milrinone. So I think that was probably a correct choice. We have to do a lot of time the forth and back, the trial and errors between the milrinone, dobutamine, sometimes even epinephrine, depending on the lower amount of the blood pressure. I usually tell this one, there is no right or wrong answer. Whatever makes the heart rate better and the lactic acid better is the better choice. There is no right, and you can try with the milrinone and then it causes severe hypertension, heart rate goes up, lactic acid goes up, change it to the dobutamine and see what happens. I think it's a different kind of situation. So with that, I will say thank you very much and I'll be happy to answer any question. I have another lecture downstairs, but I will come back for the question answer. Thank you.
So today I am here not to teach you the therapeutic 5-drug regimen. I am just here to sensitize you to how to tackle a tuberculosis patient when he comes to the critical care and talk to the family, because generally a TB patient in the ICU is an end game for the patient, because you all know when they come to the ICU it's really very, very critical. Just to sensitize you, you are just getting sensitized because the same regimen is there since more than 4 decades. So the incidence in TB in India last year reported was 210 per 1 lakh population. It's our Government of India's project 2025 and TB is no longer going to be there. It has been pushed to 2035. And we are all as intensive care specialists very much busy in day-to-day managing the main causes of intensive care admission. So we actually overlook a patient who has just come with some infection and which might be tuberculosis. So when you have a high index of suspicion, you should actually prioritize and always send an AFB smear. That's the first take-home message, which we generally don't do. Even in all the WAP lectures, you will see send gram stain and etc. etc. New PCR technologies have come. The respiratory biofire, 16,000 rupees test. It is always better to add a 500 rupees gram stain and AAV stain because it is easily picked if that patient has tuberculosis. Burden, we know only one published study from India. Otherwise, apart from that, 3.4% of hospitalized tuberculosis patient needs ICU. Means among 100 patients admitted in the hospital in the TB ward, only 3.4 need ICU admission. This was from Ritesh Agarwal, PGI Chandigarh. They said from their own respiratory department, only 1.7% of patients in that studied time needed intensive care admission. Among that, 55, half of them had disseminated tuberculosis, 30% of them had miliary tuberculosis, and 28 of them had ARDS because of tuberculosis. So these were the common causes from PGI Chandigarh in the studied time. Again, the number was more than 100. As you know, PGI has a very high tuberculosis load in terms of OPD. So we all as a chest specialist and intensive care also see such common scenes. Other common things, as you see here, is tuberculosis meningitis, which they did not see that much. Various comorbidities which may coexist when they come to the ICU are liver dysfunction, chronic pancreatitis, chronic renal failure, and HIV. Extrapulmonary tuberculosis like tuberculosis meningitis, disseminated TB also is seen, and patients requiring ICU admission, as I have already said, have a very poor prognosis and high mortality. So this is from Ritesh's PGI Chandigarh's article. Other causes you all will agree is massive hemoptysis due to Rasmussen's aneurysm, cardiogenic shock, known tuberculosis patient electively admitted for ICU for other reasons, for any other elective emergency surgery or any cardiac issues, liver failure, renal failure, DIC, pituitary apoplectic or stroke mimic or airway obstruction. So these are the other patients of TB seen in the ICU. What are the challenge? As I have already said, our focus is not there for tuberculosis. Old history is seldom given in the ER. Sputum is generally not available. NABH G-Nex should be asked, but it is not generally asked in our busy practice. When to suspect? Anyone who comes with TB, where severe pneumonia and underlying risk factors for tuberculosis like old age, alcoholism, patient is completely emaciated, chronic renal failure, diabetes, HIV, and on his immunosuppressive medicine. In the absence of any of these factors, one should also consider if the presenting illness is subacute, means the family may say, "Sahib, bahut divas thi bimar hoto, pan khato pito na to ghar thi nikadwanu ochu thai gyu to," whatever. Some reasons where you feel that it is not 15 days illness. It might be an illness which is prevailing for more than 4 to 6 weeks. So, or sometimes WBC count, nodular cavity infiltrates on the X-ray, or sometime when the patient has come with pneumonia and not looking good, CRP is disproportionately high. So think about tuberculosis. ARDS due to TB, definitely not uncommon. We have seen patients of ARDS due to TB, and we definitely have to follow the same definition and treatment algorithm of ARDS, that's the Berlin definition. The pathogenesis is because Mycobacterium sometimes triggers the intense inflammatory response, and there may be intense granulomatous inflammation and causing obliterative endoarthritis that can lead to ARDS in tuberculosis patient. Diagnosis, as I have told you, CT may help you, ultrasound will not help you, and definitely the one thing which will help you is either tracheal sampling or a cautious ball, quick look and take the samples and do a gene export. The treatment of ARDS is the same, not going to detail, I am just sensitizing all of you. TB meningitis, it is one of the most severe form of tuberculosis coming to the ICU with more than 60% mortality and residual neurological disability in 25% of cases. And unfortunately, these cases are admitted in the neurologist era, and they always have a goody-goody picture. They said treatment has been started, he'll do better. But when it comes to the convulsion, when it comes to hydrocephalus, definitely then they raise their hand and then say, because of a complication of tuberculosis, the counseling actually is delayed and the relatives are not sensitive. And ultimately, when such patient because of convulsion land up in intensive care and we end up intubating them, the relatives are not in a good mood or good acceptance time. So the children, HIV and those with miliary TB are at higher risk, and clinical features of TBM are definitely indolent with some headache, some fever, not eating well, lethargic. So they are, as I said, are generally admitted in the medicine/neurology department, and when it is time for the ICU, it is already too late. Diagnosis, not going to detail, all of us know. In the era of imaging, contrast CT versus MR brain with epilepsy sequence can give you a lot of clue in what's happening in the brain. Management, you all know airway protection prevails here. Generally, we are not allowed to intubate as if the patient is admitted under neurology till the patient is definitely seizuring away or he has high risk of aspiration or clinical evidence of aspiration or other areas like shock and continuous vomiting. So that is where it is. Have a low threshold to intubate them, start treatment, edema lowering measures. There have been trial where they said 3% is better as compared to mannitol. So that's one thing. Second is corticosteroids. Corticosteroids is definitely helpful in patients with tuberculous meningitis. Neurosurgical intervention, that is a VP shunt or ventriculostomy, are indicated in patients with non-communicating hydrocephalus and communicating which are not responding to traditional therapy. Supportive case, like all of you know, CSF elevation of head endobase, CSF drainage, use of anti-epileptics, avoidance of hypothermia, avoidance of hypotension, hypernatremia, hypoglycemia, hypoxemia, hypercapnia, and sudden increase in ICP due to coughing while the patient is on ventilator. So remember, any patient of tuberculous meningitis on the ventilator, do not stop sedation unless you are very sure that the patient doesn't have raised ICP or he is having a controlled way of no EEG evidence of seizures. If you don't monitor the EEG on your daily regular basis, you should actually be giving them mostly minimum dual anticonvulsant therapy. TBM prognosis. Despite adequate treatment, tuberculous meningitis has a high mortality and morbidity. Factors associated are delayed diagnosis, delayed treatment, high MRC severity grade, low CSF lymphocyte count, high CSF protein, and presence of hydrocephalus and MDR-TB. TB associated septic shock, again not a new thing. I was surprised to read this article. It's a very old article, 1970s it was published. It was initially called sepsis tuberculosa gravissima or Landuzus sepsis, sepsis tuberculosa acustissima. Apart from HIV, if the patient comes like this, it is actually a very bad news. If the patient comes off tuberculosis with septic shock, it's a bad news. Challenges, apart from diagnosis, treatment of TB in ICU could be complicated by absorption of drugs, presence of vasopressor, which again alters the absorption of drugs. First line AKT and the bacillary clearance takes at least 2 to 3 weeks. All of us know as TB specialists. So you don't accept a great clinical response when the patient is in the ICU. And drug-induced liver injury, all of us know. Those patients who come with drug-induced hepatitis and hepatic encephalopathy, be very, very cautious in telling them you were started on AKT without tissue diagnosis, because then that can be a very negative thing to the primary clinician who started the AKT. Generally, the patients who come with drug-induced liver injury, that's DILI, actually do not have tuberculosis, or if they have, they were not monitored in the first 2 to 3 weeks. Drug-induced doses in renal dysfunction, I have already given the slides to Dr. Amit, so he can share with you. MDR presenting with a massive stroke. This patient is currently admitted under me. She was having a good clearance. Three months back, I started her on AKT. Last week, she presented with massive MCA stroke. So she is on the vent, GCS of 5. She is currently admitted. This guy with RV failure is case of NTM, Mycobacterium abscessus, currently admitted in the critical care unit. He has got a right destroyed lung, right lower limb abscess which was gone. He is on NTM therapy since 1.5 months, but this time is presented with severe RV failure. This patient is currently admitted in intensive care. Tuberculous spine, on AKT since 3 months, but weight base was not given. Then she developed a paraspinal abscess. Currently, she has been admitted with adrenal insufficiency, septic shock, and platelet of 40,000. We started on high dose steroid. Currently, she is settled. She is only on oxygen, GCS 15/15, but she is awaiting the final surgery, which will happen this week. There is again a girl who is under my care, 10 months of AKT, and has come, last 2 slides, has come with a pulsatile swelling with a cold abscess. After 10 months of AKT, as you see here, the day for yesterday we got her operated. This was a large necrotic paratracheal node which burst open here, and she underwent a second surgery. First surgery, as you see, the scar was there. We operated on her for diagnostic lymph node biopsy in the month of June. So, because she didn't respond to first 3 months of AKT. So 10 months of AKT, she had a new de novo, probably iris. We don't know, gene expert has come, which is sensitive. I don't know why did she develop a cold abscess with the necrotizing paratracheal and mediastinal nodes. So to conclude, to be in ICU, the prognostic predictors are underlying destroyed lung, as we have that patient, high Apache score on admission, hyponatremia, low PF ratios, advanced age, and sepsis have to be identified. as a risk factor for mortality. You have to be very sensitive when such patients come to the ICU. Most of our private hospitals are not equipped to take TB patients because of risk of airborne infection. But I think your hospital has a great isolation ICU, but most of us are not having that privilege to manage. So I showed you 4 patients, all barrier ward is full because of all these patients. So our hospital doesn't allow us to keep such patients unless the AFB is negative with common ICU patients. Complications which may be anticipated in mechanical ventilated patients are pulmonary hemorrhage, pleural effusion, empyema or pneumothorax. Take home message, think TB, see TB, report TB, prognostically talk TB and promptly act if it is TB. With that, I thank you all.
Today I am starting with a very basic topic of nebulization therapy in ICU, which is a basic and integral part of ICU care. And as you all know that in last week we had a lung transplant done under the able leadership of Dr. Kumud Dittal. He is present in the audience. Sir, many thanks for please give a big applause for him. And we are proud. Dr. Pranav Modi was also here as a part of surgical team of lung transplant. And at this juncture, I would like to thank and congratulate our able thoracic surgeons. So I am from a very complex lung transplant. Today I am talking on a very basic thing, that is a nebulization therapy in ICU. So it is either in a ventilated patient or those who are not requiring ventilator, who are spontaneous breathing on oxygen. Either ventilator may be invasive or it can be non-invasive ventilator. What should be the strategy applied? So what are the goals of nebulization therapy in ICU? Is to relieve the airway spasm, to humidify the airways. It is an anti-inflammatory therapy, like we are giving inhaled budesonide or steroid as an anti-inflammatory measure, particularly in obstructive airway disease. To prevent the respiratory complications such as airway inflammation, obstruction, atelectasis, infection and asphyxia, because these are the commonest problem which hampers the smooth running in ICU and produce several hurdles while weaning from the ventilator. And giving a promote expectoration, like we are using MESNA or mucomix nebulization for promoting the good expectoration and a mucolytic action for this particular medicine. Now going to the basic slide of type of nebulizer. What are the types of nebulization? So they are either jet nebulizer, which is a pressurized gas from a jet passing from a tube, causing low pressure zone that brought the liquid formulation into the jet stream, and by Bernoulli's effect it will producing the nebulizer droplets, and droplet size is usually more than 5 micron. It is a very simple, economical and basic nebulizer. Then comes the ultrasonic nebulization. There is a piezoelectric crystal which converts the electric signal to high frequency vibration in the liquid and forming the aerosol using cavitation and capillary mechanism, which is slightly expensive than the jet nebulization and able to generate large quantity of aerosol, and there is no noise associated with it. Then comes is a vibrating mass nebulizer, which is most expensive. Aerosol is producing by the forcing the liquid using the micro pumping action through the vibrating mass containing funnel shaped holes. Droplet size is low, which is less than 5 micron. Advantage it is there is no noise, it is a compact in size. So this is an overall review of the literature of using different sort of nebulizer. The most common and most economic is jet nebulizer. It is slightly noisy. There is a residual volume, because at each nebulization there is some residual volume lies into nebulizer chamber, which makes it less effective. Drug preparation is needed. Dose is high. Treatment time is longer than other ultrasonic and mass nebulization. Output rate is low, and there is a common chances of contamination because it is open. You have to detach the secret and administer the jet nebulization. Then comes the ultrasonic nebulizer, which is also work on electric mains, which has also a high residual volume of 0.8 to 1.2 ml of volume, which remains at the end of the entire nebulization process is completed. A drug preparation is needed. Treatment type is intermediate, while if you in case of mass nebulization, the treatment time is very short. So in a short time you may able to have a good nebulization and you can finish the nebulization with the mass nebulization. So mass nebulization is the expensive out of all nebulization, and the treatment time is short. So if you are administering a aqueous solution, or if you are using a inhaled or nebulized antibiotics like colistin or tobramycin nebulization, the mesh nebulization is ideal, because if you are using ultrasonic nebulization, it will produce some heat inside the nebulizing chamber, and there are chances of some drug destruction as a result of this heating mechanism. In several ICU, there is a use of MDI. So there is a special device of in a circuit, ventilatory circuit, where you can use a metered dose inhaler and you can give directly metered dose inhaler in a ventilated patient. However, here the drug which is reached to the patient lung may be low, and there is a special circuit is required to use this type of metered dose inhaler. Now, aerosolized medication can greatly benefit in critical ill patient with respiratory disorder, but there is some difference between a spontaneously breathing patient and mechanically ventilated patient. So, drug delivery may be less effective in ventilation patient because there is a gross ventilation perfusion mismatch, and those who are ventilating, they have abnormal lungs, not like a normal lung, so they don't react in the similar manner. Like if you give a nebulization to asthma patient, they respond very quickly, but if the same patient is on ventilator and you are giving nebulizer, you will not get the optimum result because of the several issues associated with it, and aerosol deposition may be reduced during the ventilation. Now coming to the very important part, that is a nebulized drug. It is used in healthcare associated pneumonia, ventilatory associated pneumonia, and ventilator associated tracheobronchitis, which is primarily reserved for multi-drug resistant pathogen. Recently, we have got one difficult patient having a bilateral pneumonia, and there were 3 organisms detected from the ball. One was Acinetobacter, another was Klebsiella, and third was Aspergillus. So all 3 organisms in a single patient. And Acinetobacter was completely resistant to all the antibiotics available. So patient received polymyxin as a IV and colistin as a nebulized drug. So it will act as an adjuvant treatment for treating such sort of ventilator associated pneumonia or healthcare associated pneumonia. Primarily used as a salvage therapy. It is not a solo therapy, so you have to use it with other potent drug which is likely to be more effective for failing patient, and as a adjuvant therapy, as a MDR gram-negative organism has been identified. Advantages are that it is a less systemic absorption and toxicity. Suppose the creatinine high and you are not able to give colistin in a systemic formulation, then there is ideal to give a nebulized antibiotics. So this is a intravenous versus inhaled antibiotics. So if you are treating a MDR pathogen like MDR Acinetobacter, MDR Klebsiella, which is very common in ICUs, so if you give a intravenous antibiotic, you require more MIC level to reach to a target organism and to kill that organism. If you are using a similar drug as a nebulized form, there are chances that you will reach good MIC value because there are more deposition in the pulmonary tissue, and there is a more chances of eradication of this organism. But as I have told, it should not be used as a solo drug because it is not that effective. You have to use it along with some systemic drug. So factor that can affect the drug delivery in a ventilator patient is a nebulizer, ventilator, circuit, patient, and what drug you are using. So these are the factor conductive effective aerosol drug delivery in critical ill patient. If the patient is mechanical ventilated, slow flow will facilitate the drug deposition, long inspiratory time facilitated the deposition, NIV can be used with nebulizer, high PIP will reduce the drug deposition. If you are using a larger airways, then there are more chances of drug deposition than the smaller airway size. For tracheostomy, use the T-piece interface. Humidification, remove the filter before applying a nebulizer. A clear and patent airway, so you have to do good suctioning before starting a nebulizer treatment, because if there are lots of secretion in the trachea or tracheobronchial tree, then there are less chances of drug deposition. Particle size is 2 to 5 micron, then there is a good drug deposition. Sometimes we use off-label use, like we are using amikacin, which is off-label drug, or there is no any standard formulation available, and if you are using such sort of off-label drug in a nebulizer, you have to be careful about the several side effects associated with it. Vibrating mass nebulization is used for aqueous solution, and ideally all antibiotic administration in a ventilated patient should be through vibrating mass nebulization, because it got good drug deposition inside the lung and bronchi. Meter dose inhaler is used with a spacer, which is not a very common practice. And in non-mechanical ventilated patient, ask the patient to take a slow and deep breathing pattern that will helpful in drug deposition. The particle size is also 2 to 5 micron, and expiratory filter is also being advocated to reduce the environmental contamination. Now,
Last 2 minutes, sir.
yes, last 2 slides. So there are several limitations of aerosol therapy in intensive care. It is potential to cause systemic toxicity. For example, if you are using aminoglycoside, there are chances of nephrotoxicity. Toxicity in form of airway irritation, cough, and sometimes it produces bronchospasm also. So be careful, always evaluate that any deterioration is not related to inadvertent nebulization therapy. Worsening of hypoxemia and secondary arrhythmia if you are using the nebulized therapy in a low EF patient, or they have tendency to develop arrhythmia, be careful and titrate the dose, whatever, and don't override the doses. Pulmonary injury when using aerosol therapy, ventilatory malfunction and obstruction of the expiratory filter, and you have to modify some ventilatory parameters to use it. When there is a high PO to FiO2 ratio, the antibiotic may or may not be effective. With high PEEP requirement also, the drug deposition may reduce, and there are environment contamination resulting from the aerosolization of the drugs in an open circuit system, which poses a small but significant risk to the caregiver. So this is a very important for the guidance of nebulization in COVID, because we have all experienced the COVID, and at the time we have tried to reduce the nebulization practice in our ICU, and whenever there is a mandatory, then only we use the nebulization. So place a surgical mask on the face of the infected patient if your patient is receiving nebulization through HFNC to reduce the high emission of infected particle. Though there is no any consensus that nebulizer particle is likely to infect, but as a matter of fact, and to protect our healthcare worker, we have to be extra vigilant in giving nebulization in COVID. Use mesh nebulizer if available, because it is a closed circuit and you don't have to detach it from the ventilatory circuit. Avoid the use of jet nebulizer or meter dose inhaler. Attach a HEPA filter to expiratory limb of ventilator to reduce the second-hand aerosol exposure and prevent the transmission of infectious droplets. And do not combine aerosol therapy with either chest physiotherapy or any added physiotherapy or any services whenever the nebulization therapy is going on. Thank you very much.
The topic at hand was basically ILD, but because of the shortage of time, we will be sticking only to IPF and what we know so far and what are the recent things that have come up. The problem with this is that how do we catch it early? Now, starting with this is not too back ago in 2017-18 when there was a study that was done, and unfortunately we found that a lot of physicians and physicians who are practicing chest medicine, about 30% could not identify that ILD and IPF are different, and they were using it interchangeably. And this was published in JAPI. 45% could not identify the important aspects that will pick up an IPF. Many of us could not actually say that what are the two available antifibrotics that we have that can give benefit in IPF. And about close to 40% of the physicians were still using a lot of steroids and immunosuppressants like azathioprine. So this made me wonder that let us go on these aspects. The point of diagnosing IPF is not just diagnosing it, because it's a diagnosis of exclusion. So we need to first identify the UIP pattern to differentiate it from a non-UIP pattern. Then with the appropriate clinical settings, we can identify it as IPF after a multidisciplinary approach. This is the thing that I want to really say. Also, adding on to the challenge that we all face is that whatever guidelines we have had so far, they are not real world situations. The kind of patients that have been taken up for trials are mild to moderate. Unfortunately, I think all of us will agree that the kind of patients we see in a daily practice have a far bad, worse lung function when they come to us. So those kind of guidelines sometimes might not be, a true picture of the real situation. So that's a challenge that we all face, and we are keeping on evolving, and newer guidelines are coming up where we are able to actually say, okay, whether this is UIP or not. Why is it so important? It's because if it's a UIP, that means that we are ruling out the other factors. The prognostication is different. The management strategy is going to be different. We are going to be having a very low threshold for referring these patients for lung transplants. So that is why we need to identify UIP. But having said that, not all UIPs are IPF. So we discourage our radiologist friends to do not use, even if we see a classical UIP, please let us not label them as IPF before a proper multidisciplinary approach. So the two aspects that have come up to actually identify is, as you can see the arrow marks, the dilatation of the terminal bronchiole that is causing a traction broncholectasis, then leading to a traction bronchiectasis. As we move further in the coronal section, we can see that this kind of dilatation keeps on moving further up till the hilum. So then we see a traction bronchiectasis. We have to understand that not all patients will have traction bronchiectasis, broncholectasis. It's going to be a continuum. It's a natural progression of the disease, so we need to catch it early. We need to catch traction broncholectasis to actually pick up a UIP pattern. Second factor that we have is going to be the honeycombing. Now, initial concepts in 2018-19 was that we need to have stacks of cysts like this lined up together to actually call it honeycombing. But now we know that they're basically just dilated, with architectural distortion cysts. So even a single line of this honeycomb cyst in the periphery is enough to call it honeycombing, and we can actually label it as a UIP pattern. So what is the challenge really if we can find it so early? But the problem is that not all these patients, very heterogeneous disease. Some patients will have some aspects of it, some patients will have some other aspects of it. So we have terminologies like a classical UIP pattern, where when we say it's a proper UIP pattern, we say that we are able to have a good concordance with the histopathology up to 90%. So for that, to say with confidence that it is definitely UIP pattern, we need to have this kind of a subpleural basal distribution, heterogeneity, and all these things to actually call it. Anything that is below this, there is going to be some variation of adding on some ground glassing, not too sure about the distribution, but definitely subpleural, then we say it's a probable UIP. The newer guidelines are trying to club both the probable UIP and UIP together, but because in the real world situation, most of the pulmonologists feel that the clinical outcome of a probable UIP is slightly different from a classic UIP in terms of the mortality and survival. So we are still trying to differentiate between the two, because as far as prognosis is concerned. Thirdly, anything that is beyond these two patterns, that is called an indeterminate, because there is no clear-cut pattern. Anything that is beyond this, as you can see here, that there are a lot of ground glass, there is no subpleural sort of association, there is no heterogeneity, so we don't know what it is. In all these kind of patients, we will need a proper lung biopsy. That's another challenge that we will be facing. And all these CTs that we keep on seeing, that you have some sort of a perilymphatic spread, there is a second panel is an organizing pneumonia pattern that we see mostly in our connective tissue disorders, and likewise then you have a lot of cysts coming up. Look at the third slide where you see the periphery is spared. So we should not label these patients just because there is so much fibrosis, we should not label them as UIP. Also, when you call a patient as UIP, I want to show that there is this pattern. So a good quality HRCT is paramount importance. We need to have an inspiratory, expiratory scan. We need to have a lot of, proning and coronal sections to actually pick up. This is HP. You can see that there is a triple sign. The 3 density signs are seen that is showing their air trapping. Then you can see such exuberant honeycombing that is limited to either anterior segments, or there is a cutoff sign. You see that's a CTD-ILD. So we need to have an MDD approach, take a BAL, rule out the infections, and in all patients who are not classic UIP, you might have to need a histopathology. The question here is, what kind of histopathology can we use? We cannot go for a surgical lung biopsy in all these patients. Look at the kind of patients that we are getting, very hypoxic PH patients. You put in a scope, they will exacerbate. So question of sometimes getting these patients for a surgical option might not be there. So the new kit is we have TBLCs right now. This is basically cryoprobe that we use for bronchoscopy, get good chunk tissues, at least 3 tissues that can be as good as a surgical lung biopsy, and a lot of meta-analysis have shown, they call this study, that with a good MDD combined with a good, if you are able to take a good sample, then it is as good as a surgical lung biopsy. Now, adding on to this, we have a lot of studies that are happening when we have a lung tissue, and there are a lot of, we can do a genetics, sampling, where there is a lot of interest there in MUC5G. So this gene has been shown to be the marker or the genetic, predictor of fibrosing on UIP pattern. So if you have a good tissue in a good clinical situation, the pathologist saying that this could be a UIP, and you run this test and you find that this genetic mutation is there, then the specificity of identifying a UIP is 95%. But the problem is that this sensitivity is very low, and that is why it has not found its place in the recommendations right now, because we need more and more samples to actually, pick up this. Another point is that we'll only pick up UIP. It doesn't mean that it is still IPF. So you need to again go back to the multidisciplinary approach and pick it up. Now, once you have diagnosed, the questions that we do, or what are the kind of ideal patients who will need an antifibrotic. So as far as the guidelines are concerned, mild and moderate cases, but even in severe cases where the FVC is low, we should consider an antifibrotic and start prognosticating the patient and trying to make them aware of the lung transplant options available. Now, if you have a normal lung capacity, FVC, which is near normal, would you still start an antifibrotic in IPF here? Yes, we need to start in IPF, because the rate of progression of the fall of FVC, whether you start at a normal lung function or you start at a mild to moderate dysfunction, is going to be the same. The point of starting any antifibrotic is try to minimize the fall in FVC, because that's all we can offer with the medications we have so far. The only thing that is going to modify the disease is going to be lung transplantation. But as far as the pharmacotherapy is concerned, we need to start the antifibrotic. How long do we give? As much as possible. As much as the patient can tolerate, the patient should be given. There are studies of analysis where the patients have benefited with nintedanib for more than 4 years as well. The question I did not put deliberately is which antifibrotic triumphs over the other. We still do not have any answers, because we don't have head-on-head trials about these two. But as far as the real-world situation and the other analysis suggests that somehow nintedanib is more tolerable than the pirfenidone. So therefore, the patient is able to take nintedanib for a much longer period of time, and therefore we are able to see better outcomes out of it. Just 2-3 more slides. So what do we do?
2 minutes more.
Yeah. So how do we monitor them? We need to do functional assessment, the FVC, diffusion, 6-minute capacities for every 3 to 4 months, so that we are able to pick up the ILD progression. Anytime the FVC falls suddenly about more than 10% in the first 3 months, we know that this is progressing beyond whatever therapy you are giving. Please send the patient for a referral to the lung transplant. Do the pulmonary rehabilitation more scientifically, nutritional support, and very importantly, the comorbid conditions. IPF patients, 50% have CADs, they have reflux disease, please treat them. Just 3 slides more on experiment. So this is basically a collagen PET, where researchers have found that before the onset of the fibrosis on CT, if you are able to pick up this collagen deposits, it's going to predict the fibrosis much before the clinical manifestation of PFT. So this is still experimental, but this we are already using KL6, not commercially, but in most of the research setting, KL6 is a biomarker which can actually predict a bad outcome or mortality and a bad rapidly fibrosing phenotype of an ILD. So KL6 studies can be done. Another thing is that we have now AI-based algorithms in the CT software, where look at the panel on the left, you can see that definitely the fibrosis has increased, but it's very difficult to actually quantify the kind of fibrosis that this patient might be having. Now we have algorithms and AI-based studies where we can actually look at the volume of fibrosis. Every 3-6 months we can actually look at the volume, and they'll give us like a graph, so that we know that yes, in these areas the fibrosis is increasing much before it has picked up by the PFT deterioration. So that's also something that studies are going on. So the take-home message for all of us here is UIP versus non-UIP phenotyping is very, very important. We need a multidisciplinary approach. We need BALs to roll out BAL lymphocytosis, infections and everything. Probably the role of genetics and biomarkers, we still have a long way. It has not found its place, its recommendations, because we don't have real-world studies for it. But yes, in the future, maybe 5 years down the line, we'll be talking more about it. The choice of antifibrotic again depends on the patient tolerability, and a lower threshold for lung transplantation is needed, and again rehabilitation, nutritional support is very, very important. Thank you very much for patient listening.
The lung transplantation is the most difficult transplantation because all other transplants, once the patient recovers, they are in the sterile environment. The organ is sterile, but lungs are continuously exposed to unsterile environment. So it is the most difficult transplantation, and we know there are a lot of complications, infection and rejections. Patients are dying due to that also, but still the outcomes are good. Those patients who do well, they really do well. Their quality of life is very good. We'll see all the data which is there. So now first human lung transplantation was done in 1963 by Dr. James Hardy and colleagues, and 58-year-old patient of left carcinoma lung was single lung transplantation, left lung transplanted, but patient died after 18 days of infection due to infection and renal failure. There were other transplants were done after that, but most of the patients, they died within months. First ever long-term survival reported was isolated lung transplant at Toronto General Hospital. 58-year-old patient with IPF was on 24-hour oxygen support, and patient underwent right lung transplantation. Patient was discharged in 6 weeks, and patient returned to work in 3 months, and he died more than 7 years after due to renal failure. So he survived and he worked also for his family. So if we see lung transplantation data in India, it started in 1999. Dr. K.M. Cherian performed first double lung transplantation and first combined heart lung transplantation in the same year in Apollo Hospital, Chennai. In 2007, combined heart lung transplantation was performed at Apollo Hospital, but these patients died like within months. In 2011, single lung transplantation was first performed at Global Hospital, Chennai. So it is in India after 2011, gradually there is increase in number of that lung transplantation activity has picked up, and there is a gradual increase in the activity of lung transplantation. Here you can see the data. Pointer upon. You can see the data after 2011 there is a gradual increase in the number of transplantation. 2021 the numbers were less due to COVID. Now again it is started picking up. If we see states, Tamil Nadu is leading at present, followed by Telangana. Now Telangana is also doing as good as Tamil Nadu, followed by Karnataka, Maharashtra. Now Gujarat will be also there next year. So indications, general principles are clinically and physiologically severe disease for which medical therapy is ineffective or unavailable, and risk of death due to lung disease without transplantation is more than 50% in next 2 years. Likelihood of survive, patient should be fit enough, at least 90 days after lung transplantation is more than 80%. Many times it happens patients are referred at the end stage and patients are nutritionally very poor, cachexic, they do not tolerate this kind of procedures and the chances of survival are less. Absence of non-pulmonary comorbidity that would affect life expectancy substantially in first 5 years after transplantation, and satisfactory psychosocial profile and support system. Indications, these are the diseases for which lung transplantation is indicated: COPD, idiopathic pulmonary fibrosis, cystic fibrosis, emphysema due to alpha-1 antitrypsin deficiency, sarcoidosis, non-cystic fibrosis, bronchiectasis, idiopathic pulmonary hypertension, lymphangioliomyomatosis, and all other ILDs including all collagen vascular disorders. Whereas before lung transplantation, we have to see lot of parameters to assess the fitness and candidacy for lung transplantation. PFT, we see FEV1, FVC and DLCO. DLCO less than 40% is usually patient should be assessed for lung transplantation. 6-minute walk distance. We routinely do 6-minute walk test, which all pulmonologists should do. It is very simple test and it gives you objective parameter of the distance, patient's ability to work, day-to-day work, NYHA class, ABG, 2D echo and right heart catheterization. Types of procedure: bilateral lung transplantation, single lung transplantation, split lung bilateral lobar transplantation, live donor lobar transplantation and heart lung transplantation. Until 1989, previously heart lung transplantations were done for majority of the patients, but subsequently single lung transplantation has become more common. Now bilateral lung transplantation is the most common surgery performed. These are the data from IESHLT, that is International Society of Heart and Lung Transplantation. You can see that gradually there is an increase in number of double lung transplantation. Indications of bilateral lung transplantation: idiopathic pulmonary, almost all cases preferred is bilateral. Eisenmenger syndrome with correctable heart disease, advanced lung disease with secondary pulmonary hypertension, cystic fibrosis, non-cystic fibrosis, bronchiectasis, COPD and IPF. See this the indications with bold letters, you must perform bilateral lung transplantation. For other diseases, you can go for single lung also. Single lung, COPD and IPF can go for single lung transplantation. Indications of heart lung transplantation: Eisenmenger syndrome with unrepairable cardiac defects, advanced lung disease with severe LV dysfunction or extensive coronary artery disease is an indication of heart lung transplant. So there are very limited indications of heart lung transplantation. Even patient with severe RV dysfunction, they can also recover well after only bilateral lung transplantation. Median survival till 2017, around all over the world, around 55,000 lung transplantation are done. And according to 2016 report, unadjusted survival rates are 89% at 3 months, 80% at 1 year, 65% at 3 years, 54% at 5 years and 32% at 10 years. See, there are two ways to look at it. If you are pessimistic, you will look that around 70% patients die at 10 years. But it is a positive side also that 32% patients who are like 100% patients who are going to die in next 2-3 years. So out of those, 32% are alive at 10 years. But after 5 years, there is a gradual decline in lung function, and around 50% of the patients, they develop chronic lung allograft dysfunction after 5 years. Median survival, according to 2018 ISHLT report, median survival for all lung transplants between 2009 and 2016 was 6.5 years. For bilateral lung transplantation, it was 7.6 years versus 4.7 years for single lung transplantation. So for bilateral lung transplantation, median survival is almost 8 years. Quality of life, those who do well, they have very good quality of life. There are different questionnaires, SS, SF12, PCS, physical and mental scores, EQ5D and respiratory specific scores like SGRQ scores. They all showed significant improvement. In this study of SGRQ score was showing 47 points improvement as compared to lung volume reduction, bronchoscopic lung volume reduction, which showed only 13.4 points improvement. Lung function test, they become practically normal after 3 months, and in single lung transplantation there will be some restriction. After 5 years, lung function test starts gradually declining due to chronic lung allograft dysfunction. Blood gases are typically normal after 3 months, even after 7 days also they are normal. Employment status, this is very important. For At 5 years post-transplant, 40% of the patients are not working, 30% are retired, and 20% are still working part-time or full-time. So these are the majority of the patients for lung transplantation are above 55 years in this study. So maybe there are patients who are like either retired or not working, but younger patients, they go to work and they do well. Indian data on survival, first ever survival analysis was reported, 3-year survival reported by Apollo Hospital, Chennai in 2020. 3-year survival following isolated lung transplantation in 47 patients was 76.2%, which is at the same level as international standards. Patients who underwent single lung and combined heart lung were not included in it. And in 2021, Global Hospital also published their data. Survivals were 85% and 78% at 1 month and 1 year respectively. Here all the lung transplants were included, single lung, bilateral and heart lung. Challenges in India, late referral, infection. We are more worried of infection in India, whereas in Western world they are more worried of rejection. Organ donation rate is dismally low, which is catching up now, and cost is always a big factor in India. So here we can see that the organ donation rate per million population, it is highest in Spain, around 50 per million population. USA is second, we are at the bottom, 0.5 per million population. So these are somewhat old data, but it is catching up now. So take home message is that it is a well accepted and routine treatment for patients with terminal respiratory diseases. Median survival has significantly improved as compared to in past 2 decades. They have good quality of life. There are a lot of challenges ahead, but it is the only definitive treatment for patients with end-stage respiratory disease. Thank you.
I have no conflicts to disclose. This just tells you what the discrepancy is. The solid organ transplant numbers we're doing now are less than 10%, and I would argue in India, when I look at the numbers, that we're probably doing about less than 8% of what really we should be achieving. So how do we get to this? Let's have a look at the burden of respiratory disease. In India, it has 18%, almost 20% of the world population, but it contributes, the respiratory disease contributes to 32% of the global respiratory burden, which is a significant amount. So it features 3rd worst in terms of respiratory disease globally. Sad as it may be, we also have solutions, which is, as I said, sad. That this is a terrible game where we have to rely on somebody dying to keep somebody else alive, but nonetheless, this is what it is. And in India, we have a huge number of young people dying from road traffic accidents, which is the diminishing donations occurring in the West, where now the increasing donors are very old with comorbid conditions and very much more challenging than here, where we are not maximizing the conversion of these deaths into transplantation and even donation. So this again, just to repeat, some of this thankfully, it's already covered, but really poor number of donations. If you see India, 351 that year over in 2020, very small. If you look here, in terms of the lung transplant per million population, you'll see there were only, actually no, but there were some 4 DCDs in Ahmedabad that Vivek Kute and his team have been doing in kidney transplants. This you've heard, but what was an amazing challenge here was this was on the back of about 400 or 500 animal transplants, and the courage to have taken on somebody with malignancy with chest wall metastasis. But the point was it was a successful transplant in respect of the lung function at the end of the case, but the patient obviously died at 18 days. If we go back through the history, as has been pointed out, there's a checkered. If you look at all these famous names, they all had an attempt at doing lung transplantation. The bottom is what's important. Between 63 and 78, of the 38 lung lobe or heart-lung transplants performed, only 1 patient was actually discharged from hospital, and only 9 survived more than 2 weeks. This was largely as a result of the high steroid doses that were given and causing problems of bronchial dehiscence. And surgical techniques have improved, but that's why we are so keen that patients on the wait list are not on more than the 10 milligrams at most. Ideally, they should be off steroids. Sometimes they may have to go on their intermittent regimes, but ideally we want them as low as possible. Otherwise, it's a technical challenge where the bronchial anastomosis has a risk of breaking down. The seminal first double living lobar transplants are those gentlemen there with various survivorships, and Vaughan Starnes should be congratulated for doing the living lobar program for young cystics. And that's really died a death now in the US, largely taken up by a couple of Japanese groups, with not amazing results in the long term because the single lobe ends up being a little emphysematous, and you're starting off with an operation that potentially has a 300% mortality because you need a lobe from each parent. But until 1985, there had only been 5 lung transplants. By 2008, we've approached nearly 3,000, and now we're doing over 6,000 a year. So what are the major hurdles? Recipient selection, we've been through that. Donor shortage, donor-recipient matching. Lungs and hearts are not so easy to match. It's not like livers and kidneys that you can give across any weight, height, it doesn't matter. For lungs, it's a matter of cage size, so you have to try and fit the appropriate size lung, which in lung pathology will vary between pathology itself. So in COPD, somebody's breathing at the top of their inspiration, you don't want to give them that big, you want to give them something a little bit smaller, somewhere in between their actual and predicted TLC. While ILDs, who are really shrunk and often have loss of chest compliance, you're forced to give them much smaller lungs. So in the older ILD patient, plus 60, 65, that's deteriorating, then sometimes the best option is to give them a single lung transplant, normal size single, mediastinal shift, and that's good enough, and no change in prognosis whatsoever. So those are all the other hurdles. But if I was to say what's going to give you a recipe for success, it's the timely referral, a timely listing, good matching, optimal surgery and preservation of the organ, post-operative management, and personalized post-transplant surveillance. Okay, so this is from about 5 years ago. If you accept that we're capturing about 80%, we're probably around 6,000 plus lung transplants a year, predominantly bilateral. And the survival is there, a 1-year survival of 85%, 3 years of about 70, 5 years of about 60. If you survive the first year, which is most prone to rejection infection, then you can increase the rest by 10%. My own figures in my series, the first year of 87%, 3 years of 76%, and then institutional of 65% in 5 years, and so on. And what about the stays in hospital? You will see that the majority of patients are spending over 3 weeks in hospital, which means that if you refer late, it's almost impossible to get them out in time of your 3-week and the package costs that are in the corporate setting. In the US, it's very different. Majority of patients on the active list are those that are actually rehabilitating in the hospital setting or in the surroundings, so really highly picked patients. We don't have that luxury. How do they do post-transplant? Well, even if you look at them 4 to 5 years beyond, majority of patients are not being hospitalized for infection or rejection. It's for other causes. And if you look at their quality of life, majority, almost 80% of patients are managing pretty asymptomatic life. As you see there, almost 60% are carry on with hardly anything, but maybe even mild symptoms. Many return to work. This is the problem, is the late referral when patients are already on oxygen, they're unable to do their lung function tests and are able to do their 6-minute walk test. These patients would often not make it onto a Western transplant list because they're considered to be too frail. But if you refer this late, then the risk is very, very high indeed. And in the Indian context of just environmental and your climate handicap of conferring greater fungal infection, then the chances of expense and longer stays in ICU and therefore even longer periods of rehabilitation in hospital is prolonged. And in that case, you have to go back to saying referrals are never too early, but are sadly often too late. And there comes a point where they're so sick, you have to follow our Hippocratic statements here by saying this is futile and you have to be courageous enough to refuse therapy, because it's otherwise just an assault on a body for a lot of money without outcome. So how we address this? We have addressed this by increasing the rate of disease donation, which thankfully states like Gujarat are able to do. We've seen this conversion of the brain dead. Brain dead used to be known as heart beating. Now it's increasingly going to be called donation after neurological determination of death, DCD, that was non-heart beating donor, is now has been called cardiac death. We've taken years to change that to circulatory death, and now we're moving to So donation after circulatory determination of death, to take away the cause of death and assign it to the individual's death rather than any specific organ. There's some ethical issues around that. We don't have time to discuss it. And the use of external extended criteria donors. So greater than 55, the oldest one I've been doing is 74-year-olds, smoking history, medical comorbidities, lower PF ratios in the donor, substance abuse, and of course, use of single lungs, particularly in the older ILDs. What about, and then the use of DCD or DD organs now, whether it be controlled or uncontrolled for lungs, has been very successful, and finally the use of machine perfusion, which I will just touch on, and the future of xenotransplant and bioengineered lungs. How do we do it? Well, these are just from a chapter that you can look up, but just to tell you that what we're doing is a bronchial anastomosis, the pulmonary arterial anastomosis. Before we started doing this atrial cuff, as Hardy reports, they used to get so much thrombus in the pulmonary vein. So if you don't get the geometry of this particular anastomosis, you're prone to getting pulmonary vein thrombosis. And so we always do this atrial cuff, and finally the pulmonary artery anastomosis. I used to do it through the median stenotomy in the UK. Now we've moved on to clamshells, and where we can for the young women and men who are not too obese, or those in whom we don't expect the lung to be too adherent, or pulmonary hypertension, I'll try and do them through mini thoracotomies bilaterally, as in this particular lad with ILD. And sometimes, because of pulmonary hypertension or difficulty in matching or in dissection, we will do what's called a clamshell like this with a transstenotomy. Those are his explanted lungs. And this is this patient post-op day 1 at discharge, and at 3 months, when you wouldn't know whether he's had a lung transplant or not, continues to do well. This is the Maastricht criteria for donation pathways are following circulatory determination of death. You don't really need to look at, except to understand that for lungs we can do both controlled and uncontrolled. Hearts we can only do through controlled donation. So this is when you cannot do brainstem death testing, because there is some underlying neurology, in which case you, with the family, decide that you will withdraw life support, which requires some legislative changes in India. So what about in India? As I mentioned before, there's only been 4 DCD, I think, cases recorded in that year of 2020 in Ahmedabad for kidney transplants. And this is what I've just described to you, that lungs can be done through any of the modalities. And if we look here, the rest of the world has got a huge rise in this DCDD cohorts, with in Netherlands and the UK contributing significant number of patients to their lung transplant programs. In India, this was written a few months ago. Actually, when we look at the data, we think that use of DCDD organs will increase lung transplantation by at least 25%. And I've been, with my colleagues in Australia, been doing DCDD lungs for years without the use of machines, with excellent results. Stig Steen, a Swedish surgeon, was the first to do this as a unilateral transplant years ago, and described its success. Since then, the Australian series shows survival at 3 years at 93% using DCDD lungs, which is really remarkable. And the ISHLT registry now shows increasing DCDD transplantation for lungs across the pathologies, with no detriment to outcome when you compare it with those following the so-called brain death pathway. We don't always get great lungs, like your donor lungs, like you see on the left-hand side. Often they're very nasty, or they're over-flooded because of poor, and this is very typical, poor management or accelerated processing of a donor that really should be left to be managed appropriately for multi-organ conservation and maximizing conversion of transplants for another day or two. But we're in such a rush, and families want to have their bodies back the next day, that we end up with lungs that then might require machine perfusion to just try and get them better, largely getting rid of edema. And there are various modalities. I'm used to the one on the bottom right, which is when you actually put the lungs in this machine and bring it back ventilating normothermic on a plane or in a car. Very expensive, and you can do bronchoscopes on it, you can assess it, and if I can, let's see if this works. Can you get this to run? Can you click it? Yeah, can you just click it? Oh, there you go. Okay. So I've just taken the roof off it, but essentially these lungs, you bring them back ventilated. It's obviously sterile as you do, so you can check their compliance and so on. So this is part of the future. And I was lucky to be the principal investigator on the Australian arm of this. We showed the reduction in PGD and reduction in 30-day morbidity. So with excellent outcomes. Machine perfusion, therefore, is safe, is non-inferior to standard cold preservation, and DCDD lungs in India we could use without machine perfusion. Now, but it's here to stay, even though we don't need it all, because of the potential of doing ex situ repair on the lung. We can do lots of things to mitigate clad and so on in the future. I'm going to give you two examples, run through what happens when you have a problem with too many licenses holders. These are two examples of two states. This is one state that has got 5 approved lung transplant centers, where there have only been 4 lung donors over an 11-year period. So if you wanted to do 1 lung transplant, per center, it would take 9 years. There's another one which has got 16 approved centers. To do 1 transplant there, every center would take 3.3 years, and for every center to do 10 lung transplants would take over 30 years. If you look at the number of patients waiting on the list, there's no way they'll be transplanted. They're on a false hope to nothing. So if we follow the pattern of lung transplant rates per million population, even if we just stick to the USA, which is in the middle, we'd be doing over 10,000 lung transplants in India. So this is going to the future. Xenotransplantation has been tried from pig to balloon. Hearts has happened in man with a survival of 3 months. You can already been experimented with trying to decellularize human donated lungs, see if you can reseed them with all sorts of embryonic and mesenchymal and progenitor stem cells, to then put them in a bioreactor to get that engrafted, so hopefully you can then transplant, which has been so far done in mice. And the other thing is, not only can you get normal lung tissue, but you can also create your own personalized abnormal tissue by actually conferring the appropriate pathology to it. Therefore, you can be tested against pharmacology or various therapies. And so finally, last slide, if I was a crystal ball at 2030, I hope we'd reach a donation rate greater than 5 per million population, which elsewhere would be insignificant. But in India, if you can approach 5, you'd be doing thousands of transplants. We hope that we'll have over 1,000 lung transplants a year. That would mean 5 centers doing at least 100. There are only 5 centers in the world doing over 100 a year, and another 20 doing about 50 each. We need robust biomedical services where we can produce our own technology, and where healthy and necessary competition that is productive and collegiate to improve our things, as opposed to destructive, where we're trying to stop other people from actually doing any transplants. Where the state health services recognize that donated organs are a national resource, and therefore that resource needs to be controlled properly, and that you need to give a number of transplant approvals only based on demographic need, as opposed to a license for whoever wants it. Otherwise, you'll end up with this mess. And that hopefully we will by then have at least a 5-year mature registry, national registry, that will allow us to put in prospective data. And with the volume rise, India could become the major contributor to global data, and therefore writing the journals and the papers and the academics of it, so that you are evolving this discipline in India as opposed to having to go elsewhere. So on that, I will end, and happy to answer any questions later on.
The next 12 minutes, I'm going to be talking about complications after lung transplantation. It's a huge topic. It's not possible for me to put in all the complications. So what I'm going to do instead is I'm going to enlist the major complications. I'm going to explain 2 or 3 of them in detail. So the first, lung transplantation, we've got various aspects to lung transplantation, and the actual surgery begins not in the OT, but it actually begins in the retrieval process. So after that, it's obviously the surgery which is in the OT, and then you've got very important, and you need a very robust intensive care management of these patients. Infections are one of the huge contributors, and like Dr. Ahmed sir said, in Indian context, infections are in fact the most hazardous things, post lung transplantation, and it will be, and it is one of the leading causes of mortality in these patients. You've got very important drugs, which obviously includes immunosuppression. I'll be talking a bit about them in detail. And obviously the one dreaded word in organ transplantation, not only in lungs, is organ rejection. In the West, organ rejection is obviously the leading cause of mortality. In India, I will still say 50% infections and rejection. So at each step, I would just like to say what all can be the possible complications. Now in the retrieval process, obviously, the mechanical things, so you've got contusions, lacerations. Very important for us, we need to have a proper sizing, a donor and recipient. So planning actually begins right before the team leaves, obviously for the retrieval. Mismatch will have hazardous complications intraoperatively and postoperatively. Inadequate donor bronchoscopies and inadequate donor management. Sometimes we are faced with very young donors, 20-25-year-olds, who because of improper management ultimately, land up with a low EF and then the lungs start flooding. The donor bronchus size when you are on retrieval is also extremely important. When you've got logistics to involve, so you've got prolonged ischemia time, if suppose the organ does not reach the center in time, that will also have its own complications. So prolonged ventilation of the donor, usually we say that if it is more than 7 days, it has a direct impact on the incidence of chronic lung allograft dysfunctions in the recipients. Now in surgery, obviously the number one thing which I've written is death. Obviously it's not only a major, I would like to say it's a supra major surgery, and approximate intra-op death is 10 to 15%. Now with increased surgical proficiency is obviously coming down, and you've got other complications during surgery such as a cardiac compromise, you've got strokes, you've got vascular ruptures. Airway complications is one thing which I'll be explaining in more detail in my talk. You've also got bleeding and you've got prolonged air leak syndromes during surgery. ICU management is extremely essential, and the first 3 days is very critical, because that is when we've got the first thing which I've mentioned, which is a primary graft dysfunction which we see. I'll again be talking a bit in detail about primary graft dysfunction. Infections and sepsis is the number one killer, especially in our country. We've got a lot of arrhythmias, we've got gastric motility issues and nutritional imbalance. So all of these aspects need to be looked in detail, and we have to ensure that all of them are synced so that the patient has got a good recovery. Now infections, as I mentioned, as compared to a normal population, because it's the lungs which is always in contact with the environment, and second because these patients are on massive immunosuppression, so we've got a lot of infectious mortality in lung transplants. CMV is very particular in every organ transplantation and more so in lungs, so we need appropriate valganciclovir treatment, and we need to constantly monitor these patients post-operatively to see the CMV PCR. We need to see what are the copies of CMV which are circulating in the blood and take appropriate action. CMV also post lung transplantation, we've got a lot of work in which we have seen development of ganciclovir resistance in cases where you've got CMV viremia. This is very difficult to treat, and usually it just starts affecting all organs, not only the lungs, but we've got CMV colitis, we've got CMV you've got ophthalmic involvement, and it's really a nightmare to treat these patients. The third, which I have mentioned, I would just like to make a statement, is Epstein-Barr virus. Now PTLD is something which is known as post-transplant lymphoproliferative disorder. We've got many papers which mentions that this post-transplant lymphoproliferative disorder is seen when usually you've got a very high titer of Epstein-Barr virus which is circulating in the recipient. It is very simply, we can understand that like a lymphoma type symptom, which is usually seen in 3 to 4% of patients post lung transplants. Now drugs, as I mentioned, immunosuppressions are the cornerstone of management. The patients are going to be lifelong on these medications, which are usually a combination of medications. We usually prefer tacrolimus along with mycophenolate and steroids. Now, immunosuppression related complications, which means because you are suppressing the immunity, obviously it's very easy for infections to basically occur. And the second point which I've mentioned is immunosuppression related side effects. Now these drugs by itself have got a lot of side effects. The main limiting side effects for us are renal related complications. We see that the EGFR starts progressively falling when you are using tacrolimus and cyclosporin. They have also associated with hyperkalemias, you've got impaired glucose tolerance, you've got dyslipidemias. So you've got a lot of these side effects which we basically need to consider. Drug interactions is extremely important. Two classes of drugs which is essential are antifungals. So all your fluconazole, voriconazole, itraconazole will really shoot up your tacrolimus levels. So you need to be aware of this. And with regards to our country, we see a lot of clarithromycin which is being used, for atypical infections. So even clarithromycin has got a very big drug interaction with tacrolimus. It just starts shooting up the levels. So we need to be aware of these drug interactions. And obviously the dreaded word is rejection. Now in the West, after 1 year post lung transplantation, the leading cause of mortality are rejections. I'll be talking a bit more detail about the third point, which is CLAD, which is chronic lung allograft dysfunction. So the main complications which I'm going to discuss are these three. The first is airway, second is primary graft dysfunction, and the third is CLAD. Now the first, airway complications. Now it's very important for us to pay attention to these diagram. You can see that the bronchus, which is the main area where you're going to do the anastomosis. Now this area is basically supplied by two different circulations, which is the bronchial circulation and the pulmonary circulation. Now during retrievals, when you're harvesting an organ, the bronchial circulation is the one which is going to be cut and it's not anastomosed again. So these anastomosis for a given time do not have a bronchial circulation. They are only dependent on the pulmonary circulation, because of which it's very easy for the airway to develop ischemia. Now this airway ischemia is, even though it's a temporary phenomenon, because after a certain point of time you are going to have collaterals, but that temporary ischemia is the reason why you have these airway related complications. You can see the first diagram in which you've got the bronchial and the pulmonary circulation. The second is basically the early post-transplant period in which the bronchial circulation is gone. So you can see you've only got pulmonary circulation, and third, it's only after a certain duration when you start developing bronchial artery collaterals. Now this is one of the papers. It was done by Atul Mehta sir, in which he's just tried to give a classification of the airway related complications. So you've got stenosis, you've got necrosis and wound dehiscence at the site of anastomosis, you've got bronchial fistulas which can develop, you've got bronchomalacias, which is softening of the airway. You've also got exophytic granulation tissue deposition, and last is you've got infections. I've just got a few pictures to show you. So this is something which we call as non-anastomotic bronchial stenosis. So usually there are two areas where you'll have stenosis. The first is at the site of the suture, which is obviously known as the anastomotic stenosis, and sometimes it develops distal to the site of the anastomosis, which is what I have shown. Now the most horrendous form of the distal stenosis is something which is known as vanishing bronchus intermedius syndrome. It occurs only in 2% of cases. What it basically means, you can see the diagrams, in the first and the second. When you go into the right main bronchus, you've got the right upper lobe opening, and distal to that, it's completely stenosed. So your bronchus in bronchial intermedius is completely stenosed, and you've got no access to the middle and the lower lobes. Again, this is a diagram of granulation tissue and bronchomalacias. We see this also in COPDs, but post-transplant, again because of airway ischemia, you've got this. Now, primary graft dysfunction is a form of acute lung injury, which is a major cause of mortality and morbidity. It's very easy to understand this. It's almost like a reperfusion edema sort of a picture. And ISHLT has given basically this classification in which the first 72 hours is extremely important, and we need to calculate the PF ratio, and you need to do the chest x-rays. So if you've got an x-ray opacities with a decreasing PF ratio, it is what you call as a primary graft dysfunction. Please pay attention to type 3. This is the form which has got a 50% mortality at the end of first year. And the third point, I'm sorry, I'm just rushing because of time. The third which I want to discuss is CLAD, which is chronic lung allograft dysfunction, or in other words, we can understand this as, chronic rejections. Now, theoretically, we've always studied one form of CLAD, which all of us know. It is bronchiolitis obliterans syndrome. But ISHLT has got a very clear distinction in which they give two forms. The first is known as bronchiolitis obliterans syndrome, which we can understand as, something like post-tuberculous obstructive airway disease, is something which we see very commonly. And the second is known as RAD, which is restrictive allograft dysfunction. again, which can be, we can see we've got a lot of upper lobe fibrosis usually, which happens in these patients. This is an example of BOS. You can see the mosaic perfusion, which is quite evident in the alternate white and black areas. And this is a picture of restrictive allograft dysfunction, in which you've got massive upper lobe fibrosis, upper and mid zone fibrosis. Why is it important for us to distinguish between these two types? It's because the restrictive allograft dysfunction has got a 3 times increased mortality compared to your bronchiolitis obliterans syndrome. There is hardly any management which is present for restrictive, and for bronchiolitis obliterans, just 2 more slides. For bronchiolitis obliterans, you can still use azithromycin, which you use the immunomodulatory action of azithromycin. This is the spirometry classification of CLAD, so that is why post-operatively spirometry is a very important tool for us, and we need to see the best 2 values of the FEV1 of the patient and compare accordingly. So my take-home message is complications is a huge topic. It's not possible to finish in 12 minutes. I was even struggling to finish 3 complications in detail. Complications can occur at any time. Usually it begins, you have to have a very robust plan right from your planning to your recipient, to your retrieval, to the onset of CLAD. So the complication can occur at any time. You need vigorous follow-up, and often you need centers in which you need MDTs happening. So you've got every component of your team to give inputs, right from the surgeons to the intensivist to the pulmonologist to even the physiotherapist and the nursing staff. And last, I would like to mention is there is lots of scope for research, especially in the Indian context, because it is still in infancy. We've got hardly 3 or 4 centers operative right now, and it's got a lot of scope for research. Thank you so much for your attention.
I would like to thank you, JIC and Pulmonary Critical Care team for having me here. Just to start with my talk. So, the organ donation in India is regulated by the Transplantation of Human Organs and Tissue Act 1994. The law allows both deceased and living donors to donate their organs. It also identifies the brain death as a form of death. Now, the main problem is demand and supply. Transplanting a new healthy organ in the place of a terminally diseased organ is only hope of survival for the patients. India is constantly adding patients with end-stage organ disease, whose only hope for survival is getting normal and healthy organs in time. According to the World Health Organization date, only 0.01% of people in India donate their organs after death. Even the willful donors are of no use if their organs are not kept in healthy state after brain death, which create a serious demand and supply mismatch in transplant program across the India. So type of donors: DBD donation after brain death, DCD donation after cardiac or circulatory death, and living donors. Here we are going to focus on donation after brain death. Now, as already we are talking about the lung transplant studies here. Now, sir, worldwide, only 15 to 20% of the offered lungs are being used for transplantation. The ratio is very low, only 50 to 20%. The reasons are the lungs are very prone for the aspirations, ventilator-associated lung injury, ischemic timing, excess of fluid, local ischemia, thrombosis. That all lead to the primary graft dysfunction after transplantation. As Dr. Kapil sir mentioned, all the grading of primary graft dysfunction. And again, the primary graft dysfunction is the most important cause of mortality after lung transplant. The donor management. It has 3 phases. First is the pre-transplant phase, having pre-retrieval, during retrieval, and after retrieval. Transplant phase and post-transplant phase. Already transplant and post-transplant phase has been covered. We are going to focus on pre-transplant, pre-retrieval phase. Okay, so following the diagnosis of a brain death, a race against time starts. The progress of counseling the relatives and obtaining the consent for organ donation progress, while at the same time the intensivist tries to keep the donor's organ system viable for the donation. This process can be extremely challenging, since a number of the physiological changes which occur in the brain dead patients lead to the hypoperfusion of the various organs which are intended for the harvesting. Therefore, the proper guidance of the intensive care unit for the donor until the explantation is very important. When I was searching for these topics and different guidelines, I came across this article which was published in Lancet 2013. And this is a very useful article which provides us lots of guidelines and all the documents related to that. The most important, the pathological changes after brain death are hypothermia. It may be due to hypothermic cause, the frequency is 100%, hypotension, due to vasoplasia, hypovolemia, 80 to 79%, 97%, diabetes insipidus, 65 to 90%, arrhythmias, 25 to 32%, pulmonary edema, 15 to 20%, and cardiac arrest, 5 to 10%. The most common systems which are involved are cardiovascular system and as well as endocrinology system. So to focus on the cardiovascular system, 80% of the brain donor has circulatory shock due to vasodilatation as there is loss of sympathetic activity. Ongoing hemorrhages may be there. Osmotic diuresis, which is very common as the diabetes insipidus is going to settle out. SIRS, cortisol deficiency, impaired inotropy and chronotropy. Apart from that, there is rise in intracranial pressure lead to the Cushing reflex, which lead to the release of thousands time increase in adrenaline. And because of that, the hypertension, arrhythmias and subendocrine ischemia are very common. Endocrinology, brain death results in dysfunction of the hypothalamic pituitary axis, leading to the adrenal insufficiency and hypothyroidism. The posterior pituitary is very prone to stop functioning in brain dead patients. This leads to absolute deficiency of vasopressin and diabetes insipidus. So how we are going to proceed for the management of a brain donor? First, the general nursing care is most important, including prevention of bed sores, skin care, dressing changes, Foley's catheter, arterial and CVP lines, Rice tube, and maintenance of the body temperature. This is the most important. Monitoring. Apart from our temperature, ECG, arterial pressure, CVP, PA pressure, oxygen saturation, and 2D echo. Now, PA pressure is again the important criteria to measure. And apart from that, there are two another important monitoring are pulse pressure variation and extravascular lung water. There was one trial who was performed on span, and according to their trial, they have monitored both these parameters, and they have more lung procurement ratio. The fluid management, there is no difference in the post-transplantation outcome with use of crystalloid versus colloid. Primary maintenance fluid is a half normal saline with 20 milliequivalent per liter of potassium. Fluid has to be administered as per Holiday and Segar's formula. Ringer lactate solution should be considered for large volume boluses. If sodium more than 150, consider 5% dextrose. Now again the catch is there, this is important to maintain the need of each and every organ because the kidney needs to be perfused and lungs should be dry. So we have to keep the CVP like that. If we have to harvest the lung, the 4 to 6 minutes of mercury. If we are planning to harvest abdominal organs, it should be around 10 to 12. And if we are planning to harvest both the kidney as well as lungs, then it should be around 8 to 10 millimeters of mercury. CVP should be considered. Now, can anyone let me know what would be the first choice of inotrope if needed? Any guesses? Who with dopamine? With vasopressin? No one? With epinephrine? Norepinephrine? Okay, good. So the choice of vasopressor is from norepinephrine. Good. Yeah, so the drug of choice is vasopressin because the vasopressin deficiency is very common after a brain death and it's often a cause of shock. Vasopressin 0.5 to 2.4 units per hour is the first line vasopressor of the choice. Once the euvolemia is achieved, epinephrine and norepinephrine we can consider but is a second line therapy. Now the ventilatory management, most important. Initially there was ARDS net trial in which the 10 to 14 ml per kilogram of tidal volume was given to the patient but which lead to the higher mortality, and eventually after Masika and colleagues trial, it was started having 6 to 8 ml per kilogram of body weight tidal volume with 50% FiO2 and 8 to 10 PEEP with recruitment maneuvers. These are the ideal guideline for the respiratory management. Resuscitation target should be heart rate 60 to 120 beats per minute, arterial pressure, MAP should be more than 70 millimeters of mercury, CVP 6 to 10 millimeters of mercury, and in general already we have discussed about that. Urine output target 0.5 to 3 ml per kilogram per hour, electrolytes in the normal range, and the ABGA almost in the normal range with SpO2 more than 95%. The hormonal therapy is very important. Administer the nasal puffs of desmopressin. Now what happened, many times it is not possible, we don't get time to diagnose, to prove the DI. So it is mentioned that if any patient having urine output more than 4 ml per kilogram per hour with hypernatremia, with changes of urine and serum osmolarity, we should directly proceed with the desmopressin puffs to control the diabetes insipidus. Methylprednisolone, just to recover the cortisol deficiency, the dose would be 15 mg per kilogram per day. Triiodothyronine 4 microgram bolus followed by 3 microgram per hour infusion, improve the vasopressor responsiveness. Insulin to avoid extreme hyperglycemia, especially when the pancreatic harvesting is considered, and the blood sugar of 120 to 180 milligram percentage is targeted. Now again the coagulopathy and blood transfusions. Severe head injuries sometimes causes release of brain thromboplastin, which result in severe coagulopathies and subsequent bleeding. So it has to be managed with regular PT, APTT, APC, and transfusion of FFP, cryo or platelet whenever required. We may consider PCV when the hemoglobin drops below 7. So like this is the whatever I have delivered, the summarization of all this. Ventilation, tidal volume 6 to 8 ml per kilogram, fraction of inspired oxygen 50%, closed circuit tracheal suction, positive and expiratory pressure of 8 to 10 cm of water, recruitment maneuvers after each disconnection from the ventilators, hemodynamics, fluid resuscitation to achieve euvolemia, target CVP 6 to 8 as we are more focusing on the lungs, first line treatment with vasopressin, second line treatment with norepinephrine and epinephrine, dopamine for cardiac dysfunctions, hormonal therapy, methylprednisolone 15 mg per kilogram, vasopressin and desmopressin are needed for diabetes insipidus, thyroid replacement. And the donor management protocol, initial trials have shown promising result with respect to increasing the donor pool, particularly for the lung transplantation. Mind well, it is a long road, but it's worth it. Thank you so much.
After a series of very interesting lung transplant talks, let me take you through another aspect of thoracic surgery called VATS through a series of pictures and videos. So what is VATS? So VATS actually stands for Video Assisted Thoracoscopic Surgery. It's akin to laparoscopy of the abdomen. So this is a form of a minimally invasive surgery where you do most of your stuff without entering the chest through big incisions. So traditionally, thoracic surgery has been known to be done through either of these incisions, which is either a posterolateral thoracotomy or a median sternotomy or a clamshell incision like in transplant. So most of these incisions are big skin incisions. They cut muscles, we split bones, we retract ribs. So obviously there was a need for a procedure which is less invasive and less morbid. So hence VATS was born. And as you can see in this image, we do this surgery by 1 or 3 tiny incisions on the side of the chest. And we put in a scope inside the chest to visualize everything, right from the lung, diaphragm, pericardium, everything. And then we use certain sophisticated long instruments to do whatever we want to do in the chest. So why VATS? Because it has definite advantages over a traditional open thoracotomy. It gives you a very good vision. There is less blood loss during this procedure. Of course, the length of the incision is small, so the incisional pain is also less. It's associated with a shorter stay in the ICU as well as in the hospital. Since we are not cutting the serratus anterior and the latissimus dorsi, so there's less postoperative shoulder dysfunction. And there are studies which show that after VATS, the pulmonary dysfunction is actually less as compared to a thoracotomy. And of course, it's a cosmetically superior procedure compared to thoracotomy, especially if you're talking about young females. It does carry certain disadvantages, which is of course, one of them is a very steep learning curve. There's no tactile feedback, so it's difficult to appreciate the tissue that you're dealing with. Whenever there's a major intraoperative complication like bleeding, it's actually difficult to take care through VATS, especially in the early part of your career. And of course, it requires some amount of investment to begin a VATS program. So let me take you through what all procedures can be done by VATS in infectious and inflammatory thoracic diseases. I'll be taking one organ at a time. So we'll start with lungs. So the most common procedure that we do by VATS for lung surgeries are any kind of lung resection, which may be a non-anatomical lung resection like a wedge, or an anatomical resection like a segmental resection or a lobar resection, or sometimes you may remove the entire lung, which is called a pneumonectomy. One of the commonest condition that we operate is lung abscess. This is a right lower lobe lung abscess, and you go in by VATS, you identify the fissure, and the fissure you identify the pulmonary artery supplying the right lower lobe. This on the left hand is the right lower lobe. The upper lobe and middle lobe can be seen on the other side of the screen. Once you've identified and isolated the pulmonary artery, you put in an endostapler, you transect the arterial supply to that particular lobe that you're removing. Once the lobe is done, you can dissect the bronchus supplying that lobe, and the bronchus is transected in a similar fashion using a stapler. And the last step is to identify the vein in this case the right inferior pulmonary vein. You again put in a stapler, transect the inferior pulmonary vein, and your lobectomy is complete. Sometimes the fissures are incomplete, so you also need to additionally divide the fissures to go ahead with the limb. Another example is bronchiectasis, very common in the Indian scenario, which may be post-TB bronchiectasis. In this case, this is the left lower lobe bronchiectasis. You can see how shrunken and contracted the left lower lobe is. And you can do this surgery by VATS very safely. Sometimes we can also do it by a single incision VATS, which is called a uniportal VATS, as in this case, where all the instruments go in through a single channel. And this is the post-op specimen. A very common referral made to us by our pulmonology colleagues is fungal diseases of the lung, especially aspergillomas. The typical setting is a cavitatory lesion in the lung, usually in the upper lobes, and which has a mass-like thing in it with a reverse halo sign. And it's typical for aspergilloma. Patients usually present with hemoptysis. The surgery is either a lobectomy or a non-anatomical lung resection, like as in this case. Especially if you have a peripheral aspergilloma, you really don't need to resect the whole lobe. You would try to preserve the lung parenchyma as much as possible. And since it's not cancer, you don't need to do a lobar dissection. The important thing in this video is that look at the amount of dense adhesions and the dense vascular adhesions that are there, which is generated because of the repeated inflammatory response in these patients. And then the surgery is relatively straightforward. You just wedge it using staplers and the fungal ball is out. During COVID, we saw a tsunami of mucormycosis cases. Unfortunately, the black fungus. Not every case has been done by VATS, but a lot of them can be safely done by VATS as well. Sometimes you get rarer diseases like nocardia presenting as hemoptysis. In this case, the lesion was in the right middle lobe. This can also be safely done by a VATS procedure. Sequestrations, like in this case, the right lower lobe sequestration, intralobar. The hallmark is an aberrant artery coming from the infradiaphragmatic part from the aorta. And this is how you know that it's a sequestration. Usually the whole lung, sequestered lung part has become like a bag of pus, and this can also be done safely by VATS. Moving on to the pleura from the lung. Very often you see pneumothorax, which is secondary spontaneous pneumothorax. A lot of times it's because of tuberculosis. You see these bullae and blebs that have formed inside the lung. They rupture and cause pneumothorax. The surgery is straightforward. You do a bullectomy, which is accomplished by using endostaplers. You identify the bullous area. You fire the stapler on a normal lung parenchyma. And once the bullectomy is done, you supplement this procedure by adding a pleurodesis. This can either be a chemical pleurodesis in the form of talc pleurodesis, or you can do a mechanical pleurodesis in the form of pleural abrasion or an apical pleurectomy. A very common referral again from our pulmonology colleagues, parapneumonic effusions. Sometimes you have these multiloculated effusions. You enter the chest, there's no lung to be seen at all. You have these dense adhesions that have formed, multiple loculations. The fluid has started solidifying. So what you need to do is you get in your scope, find a place to put in another blunt instrument that will help break all these adhesions. So you start breaking the loculi with an instrument of your choice. It should be blunt, shouldn't be sharp. You keep on breaking the loculi. It's a time-taking procedure, requires a lot of patience. And then gradually you will start seeing the lung, as you can see here. And then you mobilize the lung off the chest wall. That's the whole idea. You have to free the lung from hilum to hilum and from apex to diaphragm. And if there is a cortex that has formed around the lung, you need to remove that cortex, which is known as decortication, which we usually do when you have an empyema, stage 3 empyema, classic split pleura sign in the third image. And in these, the effusion is more denser. It's actually pus and a lot of purulent flakes. Again, the idea is to free the lung from the chest wall completely, anterior hilum to posterior hilum and apex to diaphragm. Now you can see the lung coming into picture. We're trying to peel it off the chest wall. And The second part of this surgery is decortication, where there's a peel that has formed around the lung. It can be compared to an orange, where the orange is the collapsed lung and the orange peel is the thickened pleural cortex that forms around the lung. So unless and until you remove the thickened orange peel from the lung is not going to expand. So just removing the pleural effusion, the pus and the empyema is half surgery done. You have to release the lung completely from diaphragm, from chest wall, everywhere, and you need to remove that orange peel. That is very, very important. Otherwise, this procedure leads to a recurrence. So in this video, you can see we've freed it completely from, it's a very bloody operation. It takes hours together to, take this peel off. Now you can see that there's that thing on the top, which I'm holding with the grasper, is the thick orange peel. And the peanut is trying to get the lung off that peel, and it's coming out nicely. There's a good plane because it's a mature cortex. And, you progress and you kind of finish this. Another interesting component, as rightly pointed by one of our previous speakers, there's a lot of tuberculosis in our country, and it presents sometimes in myriad forms like this para and prevertebral abscess, a bilateral paravertebral abscess. So you went into the chest, we saw there's a huge paravertebral abscess from, extending from C7 to D12. So the idea is to release the pus. So as soon as we make an incision, you see that the pus was under a lot of tension and it starts oozing out. So you drain out all the pus. The next step is to start de-roofing that abscess cavity. So everything that you're seeing from top to bottom is a large abscess cavity, and this is the roof. So the idea is to de-roof the abscess cavity so as, you should marsupialize it so much so that there's no more recurrence later on. And then you leave a chest drain and leave everything to your pulmonology colleagues who manage these patients with ATT. Moving on to the mediastinum, very few indications for VATS in inflammatory setting in the mediastinum. One common indication is the descending necrotizing mediastinitis. You go into the chest, you open the mediastinal pleura and drain all that abscess and necrotic tissue. Another indication is a mediastinal abscess in the lymph nodes, which is not responding to your standard treatment, and the patient is spiking fever and not settling with conservative measures. You can go in to do abscess drainage of the lymph nodes. Like in this case, it's a retrocaval lymph node situated between the SVC, the esophagus vein, and the trachea. You see how thick the pus is, so this was sort of not responding to the standard ATT. So we went in, opened the lymph node roof, and removed all the pus from inside. And the last organ that we deal with inflammatory diseases is pericardium. You can get a case of a recurrent pericardial effusion which is not responding to conservative treatment. You have tried pericardiocentesis multiple times, but it keeps on recollecting. You can go and do a single port VATS pericardial window. So we've just made a nick on the pericardium, see how much tension the fluid was under, and then you start resecting the pericardial wall. The goal is to create a window sufficient enough so that all the pericardial fluid that's forming inside comes out and drains into the pleura, which has a larger surface area, so it's not going to cause any symptoms. And make sure that you send this tissue, this pericardial wall that you have taken out for histopathology. A lot of times it comes out to be tubercular in the Indian setting. And then you leave a chest drain and that's done. So that's it. Thank you for your patient listening. That will be all from my side.
Let's discuss something about fluid de-resuscitation. I'll take you to the problems of this fluid overload. Then we'll try to take something out of the parameters to monitor and a couple of solutions to the problem. What is de-resuscitation? Actually, it is active fluid removal in patients which are there with fluid overload, either using drugs and or ultrafiltration. Very simple. No conflicts here. Why do you want to achieve de-resuscitation? Because I use short form because of that bell. Well, we know that fluid is commonly used drug. We use fluid here, in and out here in the ICUs. Too much of fluid is associated with the endothelial injury, fluid overload, ultimately organ dysfunction, and increased mortality. That's the reason we should be having a concept of fluid stewardship as we have a concept of antibiotic stewardship. What is fluid stewardship? Well, it is called as a series of coordinated interventions, means not the single guy is managing, but the team of consultants who are managing the patients. They do a coordinated interventions to basically select the right amount of fluid, right amount of the dose, and right amount of the time. Well, that results in the best clinical outcomes, prevents the adverse events, and it reduces the cost of patient's treatment. Well, we all will agree without any conflict of interest that fluids are drugs, and we treat fluids as drugs as well. But problem here is that similar to other drugs, fluid also, they have indications, they have contraindications, they have effects, they have side effects, and of course the time to use it. Apart from that, this is just not the cosmetic aspect of fluid overload. This is associated with worse outcomes. Apart the pitting edema generally we see in our patients, not generally but many of the patients, which is not of cosmetic purpose, but it affects the organ function. Majority of the times we see organ dysfunction in the form of congestive heart failure or pulmonary edema. So apart from that, it is not only the two organs which are affected here. It affects fluid overload, affects the brain, it affects the gut, it affects the abdominal wall, it affects the endocrine system, everything. So it's not, we generally focus on two organs, but generally every organ is affected by fluid overload. Strong evidence exists for basically the existence of fluid overload and the increased mortality and the benefits of fluid de-resuscitation and a better outcome. So a lot of studies have been done. We'll go through some of them in the next slides. Well, the concept of fluid stewardship and fluid management, which was given quite a few years back, was a ROSE concept like resuscitation, the optimization, stabilization, and evacuation or de-escalation. De-escalation on the one aspect is reducing the amount of fluid rather than cutting down or removing the fluid. So it is different. But majority of the studies in critical care, they are done in the first two phases, like resus and the optimization. What we are talking about is de-resuscitation, which are stabilization and de-escalation. Not much is done in this part. We see the concept is coming up here, and few of the studies are focusing on that as well. It's very easy to use fluid because once we are graduated, we know which fluid to prescribe. Very easy. We have availability of fluid as well in our ICUs. So it becomes very difficult to control that as well. A good slide to present the concept of ROSE here. What fluid to use, when to use, how much of amount, what is our goal, how much of fluid therapy, how much of fluid balance will achieve, in what time frame. Okay, so do we really think about this, that our patient is fluid overloaded, we need de-resuscitation to remove the fluid, and if yes, why? So interesting slide here, which will give answers to our routine questions, like when to start IV fluids, when to stop IV fluids, when to start removal of IV fluid, and when to stop removal of IV fluid. Well, simple answer. Congestion is our answer to each question. When to start IV fluids, when there is congestion is present. When to stop IV fluids, before the congestion emerges. When to start IV fluid removal, after the congestion, as early as congestion emerges. When to stop IV fluid removal, when the congestion is controlled. I think if we focus on that, probably we'll answer many of our questions. How do we evaluate the fluid status of our patient? Well, parameters, certainly clinical parameters, biochemical, investigative parameters. Simplistically, we use clinical parameters, and we use our daily fluid intake chart, intake and output charts, fluid balance and cumulative fluid balance to use it routinely. Apart from that, chest X-ray, lung ultrasound, to mention few. Just because we are fluid responsive, it doesn't mean you need fluid. If we evaluate the fluid status of each of you, despite of, as Amit said, having tea and coffee, you all, including me, will be fluid responsive. That doesn't mean I have to give fluid to each and everyone, because if you see our CRP or our lactate or our urea, creat, they all will be normal. So if we are fluid responsive, that does not mean that we are supposed to get fluids. Will you give fluid to each, and if it is that, everybody will be on fluids. Just to mention the evaluation, this is a single slide for depicting the IVC status and the fluid status based on IVC. Similarly, we can get the lung ultrasound. Similarly, we can get the echo, everything. One more area of research here is to find out what is happening in the VEXUS, venous access ultrasound in the hepatic vein, portal vein Doppler and the intrarenal venous Doppler. Once the patient is fluid overloaded, there is backflow of the volume that comes back into the organs, which will guide us regarding the status of the fluid. Similarly, they have come up with the grading of VEXUS, which is, I think, beyond our scope of this 12 minutes time frame. Advantages of ultrasound would be putting it all together. We can do it repeatedly whenever it is needed. It is dynamic thing. We can get sonography whenever you want. Plus, every organ is assessed from lungs, heart, and your IVC to other organs as well. Okay, how and when do we do resuscitation? When will you start? Should we start? When the patient comes to you, when they are in dire need of fluid, like they are coming with hypotension, decreased output, other organ dysfunction, we start giving fluids. Once that resuscitation is completed, we should start thinking of de-resuscitation. We should aim for zero balance at the end of 48 hours of ICU admission once the patient has been stabilized. Patient selection is based on criteria, either their clinical signs, lab parameters, radiological signs, and altered cardiopulmonary function, which are routinely otherwise used. How to guide de-resuscitation? I think the coming up concept of de-resuscitation would be based on ultrasound, apart from clinical and lab science. Static imaging, we should not be using it. Like we get the X-ray in once 24 hours, probably better to get the lung ultrasound. Using the volumetric preload, using the fluid responsiveness, absence of fluid responsiveness, I would say. Just to sum up, I would discuss some of the papers which have come up in the topic of this. There was a survey done of critical care physicians for their resuscitation practices. If you see the answers, somebody would put emphasis on the elevated CVP, somebody would say backup, somebody would say, I would use weight, somebody on the fluid charts. So one is using, everybody has a different preference for using it. Same comes to when they are asked questions about if this was present, what will you do? The answers were different. Somebody would stop using fluid, somebody would decrease the maintenance fluid, somebody would use diuretics, someone would use ultrafiltration, etc. So their practices varies. The idea behind this is everybody practices differently. Well, BIA could be one part, but this is more of a research tool, so this is not into clinical practice. But one interesting paper was there which said that increase in blood volume by 5% is associated with the increased mortality in critical ill patients. This is old study, but good study here, which was in the patients with acute lung injury. Previously, it was acute lung injury, and aiming for negative fluid balance, which was associated with PEEP and albumin and diuretics, which was associated with the less days on ventilator, less ICU stay, and reduced mortality. So this was Radar 1 trial, which was de-resuscitation in the patients with iatrogenic fluid overload, which said that resuscitation practices they basically are individual ways. Same way, volume overload is to be counted by each and every one, and identify and try removing the fluid from the patient as much as possible. This was a feasibility study in which they try to find out, is it feasible to remove the fluid? It was feasible to remove the fluid. This was Radar 2. I think result has come up of this trial, which is mentioning that we can do de-resuscitation in the critical illness, which is quite feasible. This was one good paper here, I think this was in intensive care medicine, which says that details about the concept of de-resuscitation. So take home messages that too much of fluid is harmful, as we all know, nothing new in this. It needs multimodal assessment. If we see at one parameter, one classical findings, it will not be our goal. We have to find out by different assessment about patient's status. Then we need to put more focus on this concept of de-resuscitation for the advantage of reducing the patient's mortality, length of stay, and stay on ventilator. Perfect. Thank you.
So we all have done intubation, or we have seen intubation, or we have assisted intubation. And I'll speak two sentences which are common in every ICU, every ER or every intubation scenario. One, अरे यार हमारा वो बंदा है वो बहुत ही अच्छा इंट्यूबेट कर देता है, पेशेंट तुरंत इंट्यूबेट कर दिया. So it was one go and I can leave my ICU to him, he can intubate anyone. It's very common to hear this word. And second, I don't know what happened. After intubation, the patient crashed suddenly. It is the same guy who has intubated your patient, you are confident about, and for the same guy you are discussing a different topic now. The patient has crashed. Why this has happened? So, are we dealing with something which we are neglecting by conscious or subconscious mind? That is my question here. So risk factors in ICU patients are many. Just to name a few: poor reserve in terms of pulmonary, cardiovascular or fluid reserve itself. Already compromised muscle function due to variable comorbidities associated with ICU admission. No fasting status available most of the time when they crash and they require emergency intubation. Underlying atelectasis or other pathologies of the lung per se or the skeletal system. Other organ dysfunctions associated with other comorbidities, CNS, CVS, renal or hepatic. So these are the risk factors in any ICU patient. When we are going to intubate, all the risk factors comes into play. Major gaps in our clinical practices. These are identified by many studies. One is poor identification of at-risk patients. Second is poor planning for emergency intubation. Third is unavailability of skilled clinicians. So the skilled word is very commonly and easily used. Unavailability of specific equipments which can assist your intubation. And lack of knowledge for proper interpretation of capnography. So you may have a good gadget, but you may not have a person who can interpret it in proper way and can use it properly. What is this Makoka score? If anyone has gone through, it's an intubation risk factor scoring here. So Malampati score, obstructive sleep apnea, cervical spine mobility, limited mouth opening, coma stage, severe hypoxemia, and someone will laugh who is an anesthetist that it is non-anesthesiologist carries one risk factor. Fine. Any score after calculating this beyond 3 is considered a risk factor itself. So if you go through Malampati score 3 or 4 alone is risk factor, but any score beyond 3 is considered a risk factor. Drugs, what we have right now for intubation: etomidate, ketamine, propofol, and one, whatever you can add. But what are the pros and cons? Etomidate is more hemodynamic stable, rapid onset, and can cause issues with corticosteroid deficiency or insufficiencies. Ketamine, again more hemodynamic stable, but can cause increased secretion, and post-ketamine hallucination is common, but most of the time we are giving some kind of sedatives or antihypnotics. And propofol, very good, rapid onset, but can cause hemodynamic instability. At the same time, neuromuscular blockers, succinylcholine, some use increased during COVID time, but it is most of the time not used in ICU. And rocuronium, which is the newer one. The issue is anaphylactic risk, practically not seen by most of us who have used it. So these are the commonly used drugs. I am not putting other drugs which you would have used in past, but these are the commonly used nowadays. And these are definitely better than the ones which I have not mentioned. 2011, this was a paper, tracheal intubation in ICU. Is it life-saving or life-threatening? Dr. Divetia and his colleagues questioned this, and where they analyzed and discussed about Indian practices on intubation and safety in ICU. Then there was a paper, in 2019 which said tracheal intubation in the critical ill, where we came from and where we should go. Again discuss it in the international scenario where they had compiled that what are the risk factors and what are the new gadgets and how we can use them, what are the new technologies also. Then was this study INTUBE, which was a multi-center study, and almost 29 countries participated. The paper got published in 2021. Data collection was done in 2019. We discussed all intubation practices in different ICUs, different countries, and adverse peri-intubation events in ICU patients. So what it highlighted, we were part of the study, that 2,900 odd patients with added re-intubation in certain cases also were observed. And it was observational data where they followed them up to 28-day survival time. Outcomes measured were complication in terms of major adverse events, along with success rate, methods used, drugs used, and major reasons for intubation. So what were the findings? Almost nearly 50% intubations were done by anesthetists. 34% ICU did not have any established protocol for ICU intubations. Pre-oxygenation by bag mask was done in most of the time, and it was the preferred method. Commonest used drugs were still propofol, midazolam, and urocuronum. Direct laryngoscopy was done in 81%. Stellate was the common adjunct use. Commonest method was auscultation for confirmation of the proper tube placement, and success rate was nearly 80%, the first trial success rate. Now coming to another highlight. Major adverse effects, 45%. So we are successful in 80% of the time, but we saw almost in 45% some major adverse events. Cardiovascular instability was 42%. Severe hypoxia in 9%, cardiac arrest in 3%, esophageal intubation 5.6%, new onset arrhythmia 5.6%, difficult intubation requiring more than 2 attempts or almost 5%, and aspiration occurred in almost 4%. What does it suggest? That it is still a big deal when we talk about intubation. It's not an easy thing for every patient. We have to be as much careful as we were on the first patient we intubated. So then, after this INTUBE study in intensive care medicine, how to improve intubation in the intensive care unit, there was update on knowledge and devices. And they came up with some good flow charts. One was airway management algorithm in intensive care units, which suggested to operators, which was recommended metal blade, malleable stellate, and Makoka scoring, going for direct laryngoscopy, or if you have a good skilled person using video laryngoscope, then you can go for video laryngoscopy. Otherwise, if it is a new onset or newly developed area where video laryngoscope has been just bought and no one has used it, don't go for it. Step 1, 2, and 3, that is specifically intubation failure, mass ventilation. You can use video laryngoscopy, other adjuncts, can go for LMA or fast track, and if in emergency, go for cricothyrotomy or fiber optic guided intubation, only if it is available. You cannot wait for fiber optic to come to your ICU from your endoscopy suite. So update said that these are the specific recommendations to operators: fluid loading, if early needed introduction of vasopressors, then proper pre-oxygenation, upright position, long-term sedation, non-invasive or HFNC if possible to be used, video laryngoscope if skilled, RSI, Selix maneuver, ventilation properly. Capnography is something which should be there. If available, use it properly. Vasopressors, if needed, can increase, and long-term sedation should be started immediately to avoid any hiccups in the hemodynamic stability. Now coming to these 10 tips when you are using laryngoscope, and that is specifically a video laryngoscope, try to stick to one brand or one model, get a repeated training, and make sure that you have backup available. So unless you are skilled, don't go for video laryngoscope. It is still not accepted by all guidelines except some European countries which have accepted it as a first option. So in summary, pre-oxygenation and apneic oxygenation both are different. NIV and HFNC are preferred choices for pre-oxygenation, and severe hypoxic risk patient, you should continue back mask ventilation when risk of aspiration is low, and don't go for any waiting. Video laryngoscope, skilled hands and proper usage. Unless you are specified, don't go for it. Always have a proper hemodynamic monitoring devices and gadgets available with your resuscitation drug card. Skill refreshers and retraining is always going to help, so don't hesitate to retrain yourself or retrain your colleagues or juniors, and a set protocol definitely will help in better outcome.
This topic is, as such, is a very vast topic. I will try to concise in 10 minutes. So we'll go with this flow. So when to initiate a CRRT? So the thing is, when the kidney, the burden of solute and volume exceeds the capacity of kidney to remove it, then you require a CRRT. So it is not just the patient specific factor, that is not just AKI which will help you initiate CRRT. There are clinician specific factors like how much you are inclined to start a CRRT, how much you know how to manage it over a period of 3-4 days, then it will be started. And not just that, patient and doctor factors, the logistic factors, means availability of the CRRT machine. It happened once that we started, the CRRT was going on in one patient at CIMS, and I counseled another patient about CRRT, but the machine was not available with the rental persons, though the relatives started shouting, CRRT is not started. So all these factors helps you start CRRT. So basic indication is acute kidney injury. These are the modalities of RRT which we can offer in AKI patient, continuous and intermittent therapies. Continuous is CRRT, intermittent is SLED, which you usually do in your ICUs, and IHD, routine dialysis. So what are the advantages of one over other? So if you see CRRT, hemodynamic stability and stability of the intracranial pressure can be very well and betterly achieved in CRRT, but at the same time, due to prolonged immobilization and risk of catheter-related infections is higher on a higher side. Well, as compared to intermittent hemodialysis, that is routine dialysis, rate of fluid removal can be achieved more in IHD. Then rapid correction of the metabolic and acid-base disorders can be done in routine dialysis. But at the same time, do we require that rapid correction in such a critical patient is a question. So the difference between continuous and intermittent therapy, that is CRRT and regular dialysis, is the urea clearance. So urea clearance in CRRT is obviously less as compared to the routine SLED or dialysis, but then why we are favoring CRRT, that we will discuss. So this is a point regarding volume removal. So if you see the fluid status of the patient in ICU, if you take a simple example of a heart failure patient, he is in severe fluid overload and you want to remove 2-3 liters of fluid, but his BP his heart function is poor, his BP is almost 80 to 90 systolic, and he's on vasopressor. So if you remove the fluid in a continuous manner, this can be done only in CRRT, and that will help you attain a hemodynamic stability. So what happens in SLED and IHD, if you see the graph, the waves start increasing. So you tend to remove 2 liters in 4 hours, the BP may collapse. At the same time, if you see the clearance chart, a smooth line is there in the green line in case of CRRT, whereas there are sawtooth waves of clearance of urea and creatine or the molecules in other dialysis. So dialysis modality. So how this is important, because if you rapidly correct urea, there would be severe osmolar shifts in the body. There will be shrinkage of the cell, or the cell may be edematous and leads to delayed recovery of the patient. So this is the ideal way how we initiate CRRT. When the patient is critically ill, in first 24 hours we do CRRT. When the patient achieves hemodynamic stability, we shift to SLED. When the patient is again totally off vasopressors, we continue routine dialysis. So again a different point, early start versus late start of CRRT. So again, the pros of early start are we avoid marked fluid overload, we avoid marked electrolyte abnormalities. As we discussed in that cardiac patient, if the urine output is 10 ml per hour and you wait for it for 3 days, urine aase, but if urine doesn't come, and at the end of 3 days you are severely fluid overloaded, now you start CRRT or any other modality, you try to remove fluid, so BP will collapse. So it was a good decision if you would have started it early. These are some studies which do favor early start versus late start. So clinical indications of starting a CRRT, AKI, azotemia, fluid overload, but there are some other non-renal indications also, like if you want to remove any drug, cerebral edema. So because of slow urea clearance, because of less this osmolar changes in the blood, the cerebral edema is properly controlled and managed. Some crush injuries, sepsis, ARDS. So why fluid status matters? If you see this study, per 10% increase in the fluid overload of the body increases the mortality by 1.78%. So if you see this chart early, the second one, about 20% fluid overload, the survival was less even if you started early CRRT, and with low fluid overload, less than 20%, the survival was much better. So, but now second indication and the foremost indication which you find in ICU patients is sepsis. So how does CRRT help from, apart from dialysis, routine dialysis in sepsis? So CRRT obviously will clear your solutes, but apart from it, it will act as an immunomodulatory therapy. And how? We will understand this by discussing the modality of CRRT. So routine dialysis will clear only the red portion, that is urea and creatinine. CRRT helps you correct the middle and higher molecular weight substance, which are your cytokines and endotoxins, which are not removed with SLED. This can only be removed with CRRT. So how does that happen? By the principles of CRRT, which we won't go in detail, but routine SLED only helps you remove through diffusion. We achieve convection adsorption only in CRRT, and those are the therapies, modalities through which you will remove cytokines and endotoxins. So these are the different modalities of CRRT which you can do in your patient. SCUF is only fluid removal. So the cardiac case we discussed, maybe his creatinine is 1.5, you don't require a dialysis, you only require fluid removal and with a slow rate, so you can go for SCUF modality. CVV HD is continuous veno-venous hemodialysis, which will remove only the small molecular weight substance. CVVH and HDF will remove the small, medium and large molecular weight substances. So in short, if you want to remove only volume, you use CUF. If you want to remove solutes and volume, you use HD and HDF. And if the patient is severely hypercatabolic, you do CVV HDF. So how do you achieve that clearance? We using these membranes. The membranes has additional effect of, AN69 membrane has additional effect of adsorption also. So this is the Oxyrus filter which we use, this is the cartridge which we use, and this is a heparin coated. This has 3 layers. First is heparin, so you don't need to anticoagulate the patient. The second layer adsorbs endotoxins and the third layer adsorbs the cytokines. So if you see, this is the data which shows that your interleukin 6, 10, procalcitonin, these were removed significantly. P-value is significant, means almost 75 to 90% were removed. This removal is not achieved using SLED. This removal is only possible in CRRT. So this is an Indian experience. So if you initiate early, then vasopressor reduction was achieved in 68% of the patients, SOFA score reduction in 72%, urine output increase was there in 48%. But remember, we tend to start it late because of some misconceptions of us that only when the BP is 60 or 70 systolic, when the patient is on triple vasopressors, then only we will start CRRT. It is not the case. In US, they start CRRT in every patient. They don't use SLED. They use SLED rarely. So even if your BP is 100, 110, it's on only one ionotrope, ideal way is to start CRRT. Selection of anticoagulant. So now if you will say that you don't have much indications of CRRT, you can't start it in surgical patients because of heparin, you can't give it in this hemorrhagic stroke patients. So nowadays we don't use heparin in CRRT, we use regional citrate anticoagulation. So what is regional citrate? We infuse citrate before the cartridge. Citrate chelates the calcium, so there is no coagulation cascade activation in the cartridge, and again we replace calcium from the peripheral line. So what happens is the coagulation portion is limited to the cartridge. So that helps in running the cartridge for 6-7 days as opposite to the thinking that the cartridge lasts for 1 or 2 days. This helps us save the cost. Even the KDIGO, nephrology KDIGO guidelines recommend now citrate CRRT only, not a heparin CRRT. So these are the fluids which we use for doing citrate CRRT. The we have fluids with different constituents which we need as per the patient's metabolic conditions. If patient is hyperkalemic, we can use 0 potassium containing fluid. If patient is hypokalemic, we can use potassium with 4, and so as other parameters. So last point, the dose of CRRT. So it is very important to achieve the adequate dose of CRRT. Just starting CRRT and then achieving no result, maybe the first error would be the prescription dose. Usual dose is 20 to 25 ml per kg per hour, but to achieve that dose, you have to give a higher dose of 25 to 30 ml per kg per dose. And this is a flow chart how we record it. Now, one important, I will take 1 minute about expenditure. So this is the biggest hurdle of starting CRRT. But nowadays, those insured patients or CGHS or RGHS patients who are taken care of or affording patients, you should give the benefit of CRRT to them rather than SLED if indicated, so as to achieve a proper and early recovery and minimize the stay of the patient. One more thing, CRRT is also included in Ayushman card. So they sanction 40,000 rupees per day for CRRT. Actual cost is 60,000 per day. So not a big difference. You can start CRRT, you can start CRRT in Ayushman card centers also, but nobody is doing that. So this is a vast topic. People conduct 2 to 3 days conference on just CRRT. So this was in concise. Thank you.
A full circle of hemodynamics, but what I'm going to give you is everything that hemodynamics is across the world, and you can pick and choose what you want depending upon the patient and the institute you are working. So this is just a cartoon to start off with. When does life begin? One is at the moment of conception, then at birth, and then when you get your driver's license, because you get a license to do whatever you want, including killing people. So my question here is, what is the question I'm asking when I'm doing a hemodynamic monitoring? So is it a fluid responsiveness? Do I need to resuscitate, de-resuscitate, as Farooq said? What is the cardiac output? Is the heart functioning well? And are the tissues actually getting perfused? The choice of technology depends mainly on the questions we ask. So don't ask the wrong question to the wrong person and the wrong tool. So is it a static or a dynamic monitor? Is it an upstream or a downstream marker? Is it fluid status, or are we looking at fluid responsiveness? Is it cardiac output is adequate or not? And microcirculatory status is good or not? And so on and so forth. And now into 2023, do I have a monitor that actually predicts the hemodynamic instability in the next few minutes? Probably yes, and I'm going to end it with that. I like quoting Einstein, and he said that not everything that counts can be counted, and not everything that can be counted counts. This is a matter of life also, and also a number does not mean anything when I'm doing a hemodynamic monitoring. We all know that preload, contractility and afterload are responsible for stroke volume. We also know that stroke volume into heart rate is cardiac output, and we also know that cardiac output into SVR is blood pressure. So when we are looking only at blood pressure, we are actually looking at 5 other things, and we need to understand that just a blood pressure low or high does not mean in isolation anything unless we put all these together. And as Sir rightly said, what is the preload, what is the contractility, what is the afterload is important. That brings us to the 3 main shocks. I'm not going to cover the obstructive shock, and that is hypovolemic, in which there is a low CVP or a wedge, and therefore your cardiac output is low because less is coming to the heart, and then your SVR is actually high, trying to compensate and maintain the blood pressure. In cardiogenic, the prime driver is the cardiogenic shock, and here there is a cardiac output is low, and because of which the SVR is again high, and the wedge and the CVP may be high, and then if we have given diuretics, it may be normal. In distributive or septic shock, we would have a vasodilatory shock, and here we would have the SVR which is low, and as a compensation the cardiac output is actually high here, and this is one shock where the cardiac output is high and there will be relative hypovolemia. I've tried to make this a little interesting, so I'll need 2 extra minutes. I've put some celebrities in each shock, and please bear with me for my stupidity here. So I would call the hemorrhagic hypovolemic shock as akin to Shah Rukh Khan, his clear pose, and your right hand is your preload, your body is your contractility, and your left hand is your afterload. So if you actually see this, there is a low preload here, because of which not too high, not too tall, so therefore the cardiac output is low, and then trying to compensate, the SVR is high, a very similar Shah Rukh pose. Whereas the laughing Buddha is the cardiogenic prototype, and here the cardiac output is low and trying to compensate, the SVR is high, and also your PL is high, that is your preload is high. And then my favorite is the Septico Amitabh Bachchan, and that would be, there is a low SVR here, so very long hand, so it goes down, and the cardiac output is high, and therefore there would be a low or even a normal preload, and this is how I just try to teach my students, so bear with me for if you didn't like this. We also need to understand the tissue level, and therefore we know that oxygen tissue level, because the monitoring tool does not matter if you don't know the right physiology, and therefore delivery of oxygen is about 1 liter. So a 5 liter blood will always contain 1 liter of oxygen. That is the simple thing. And this delivery depends upon your hemoglobin, your cardiac output, and your saturations. This then goes to the tissues, and the 25% of this is your oxygen extraction ratio, which is going to be your VO2 or the oxygen uptake. And then comes the SCVO2, which is your venous mixed saturation, and therefore your pulse oximeter in an arterial line would have 100% saturation, but a venous line would have 75%. Now let us look at all the technologies that I have. I will go over the invasive, minimally invasive, and the non-invasive. So here, initially there was the arterial line, the CVP, and the PA catheter, which I will talk about. The arterial line, I'm not here to teach that, but just apprise you of all the modalities available. Here, the definition of mean arterial pressure is 1/3 systolic plus 2/3 diastolic. This actually is taken on the arterial line by the area under the curve, and sometimes in the exam or in life, we forget, is it 2/3 systolic or is it 2/3 diastolic? So please look at the cardiac cycle here, and you will understand that the diastole is 2/3. The more distal you go in an arterial line, like a dorsalis pedis, the arterial line waveform will become narrower and taller, but the area under the curve remains the same. And then you need to actually monitor it properly, because it could be underdamped, normal, or overdamped, and you need to actually check your arterial line. So you should know your tool very well. CVP, as sir said, all of us will listen to this lecture, but finally go back home and only use our central venous catheter as the only monitoring tool or the only useful tool. But when we use a CVP, we need to understand the assumptions that we are making with it. A CVP is equal to a RAP, equal to right ventricle end diastolic pressure, end diastolic volume, and finally preload. And actually it does not really reflect your fluid status or fluid volume very well, responsiveness, because there are many other factors, the tone or the intravascular volume, the cardiac functions, and whether the compliance is good or not, and also a tight abdomen, intra-abdominal pressure, or tension and cardiac tension pneumothorax or cardiac tamponade. So there are various factors which affect the CVP, and therefore whenever we look at a CVP, it's a static tool, but we want to convert it into a semi-dynamic tool. And here what you do is the patient self-ventilating or is the patient on a ventilator? and obviously in self-ventilation, the expiration is on the higher side and the inspiration is a negative one. As against that, we are actually looking in a controlled ventilation where inspiration is high and expiration is low, and always we look at the CVP in an end expiratory format, and that's how you might convert a CVP reading not by the number but actually a visualization. Many times you might have a very high CVP, but you might still need to give these patients fluids, and that is pulmonary embolism, cardiac tamponade, constrictive pericarditis, tension pneumothorax, and sometimes cautiously in right ventricular failure. So the infarcts. So these are the conditions in which you may have a high CVP. So much confusion in monitoring a simple thing. And finally, an article said that it's like tossing a coin. You are 50% times right and 50% wrong. So why not just toss a coin? But I don't agree. We use the central line not only for monitoring but many other purposes. The PA catheter was invented by Swan and Gans, and this goes from the RA to the RV to the PA, and it wedges there, and it actually should be in the West Zone 2, and it actually tells you the left atrial pressure. And the PA catheter, again as mentioned earlier, is actually a wonderful tool to know the right side, the left side, and the interdependence of both the sides of the heart. Unfortunately, there was an article years ago which said that those who had a PA catheter died more, and therefore it just went out of vogue. So now if you put a PA catheter, you are beyond 60, you are outdated, and you are not a good intensivist. Coming to the non-invasive, everyone says, why do invasive when you can do non-invasive, at least in the ICU? So we had electrical impedance, which was mentioned by Farooq, esophageal Dopplers, which are not in vogue, transthoracic echo, which is very commonly done, the PLR, the bioimpedance again came in, and the clear sight. So ultrasound, I don't need to tell you all here, but you can look at the B lines, you can see the number of B lines which are higher, then you would be better off with that. You can also see the IVC, which is plethoric, the RA there, and you should measure it appropriately in inspiration and expiration, and this actually is much more reliable when the patient is on a ventilator. Similarly, you could do an eyeballing and you can see that the ejection fraction, or you can do a Simpson's method and find out whether the EF is low or high. Another very important thing that you can do at the bedside is passive leg raising. It is a 5-stage approach. What is important is you have to always combine it with the cardiac output pre and post PLR. And what is important is if you have given a fluid bolus of 500, then you will again have to go to Farooq and say, now de-resuscitate because I gave 500 which was wrong. So it is not appropriate. You are using your own body fluid by doing a PLR, and a big thigh like mine would probably have 500 ml of fluid. So you are giving a 500 ml bolus, and then you are immediately releasing that. So you are not causing harm as against the other techniques. So PLR is actually good, but it somehow has its limitations, not done properly, and therefore it doesn't work very well in some ICUs. There is also something called as the PVI, or the pleth variability index, from 10 to 24%, and that's pretty useful. And then there is a technology called as clear sight. It came and it's probably now going to research. Excuse me. This is working on the clamping technology and the spectrography. And then we can also reuse our capillary refill time, but it should be done in the right way to just guide you on therapy. Minimally invasive is very interesting now, and that's really gone a full circle. We have the flow track, which uses actually SVV, which is nothing but the max minus the minimum upon the mean of stroke volume. And this uses the principle of reverse pulses paradoxus, and therefore it is used on a mechanically ventilated patient. We also should know the PPV upon the SVV difference, and it is rightly shown here in this diagram. And then we have the PICO, which was a central line and a femoral line, and these two not only gave you all the pressures and the volumes of the atria and the ventricles, but it also gave you the pulmonary blood volume, and it also gave us the extravascular lung water. So just by a visualization, you can actually see, like in this patient, there is already an extravascular lung water index of about 10, and the patient is beginning to get filled up. and then this obviously does not need any thing else except a diuresis or CRRT as per my previous ones mentioned. Now, is there any prediction? And let us look at the crystal ball here. I don't think my experience is 20, 30 years in the ICU, and I can say, oh, this patient needs fluids, oh, this patient needs diuretics. Please stop doing that practice. And we have a new tool which has actually come from the OT to the ICU. It's by the Edwards. And what it uses is a machine called the Acumen. So all your flow tracks and volley views are, just a minute or two. All your flow tracks and volley views have been thrown off, and now they have only got the Acumen, which does everything which all the other machines did, but it does something called as the hypotension prediction index, HPI. If that is more than 85, as you can see in this chart, within 5 minutes the person will have a 90% chance of hypotension. As against that, if you see, if it is 40, the HPI index, then there is only a 38% chance that after 45 minutes the person would have hypotension. This is something which is pretty useful, and it actually uses technologies in which they are looking at the ventricular compliance, the ventricular diastole, and they are also looking at a dynamic index. So this is how it calculates, and it's got an algorithm. The same machine goes one step further, and it has an infrared spectrophometry, and probably it might help in the organ retrieval here, because it actually measures the cerebral oximetry, and it gives you another algorithm that you improve the hemoglobin, saturations, CO2, temperature, etc., and try to maintain the cerebral oximetry. And it's got the same machine, but it's got these two leads here. I have not used it, but it is there available for us to use. I would end here by saying that we have two types of tools, monitoring tools, that is static and then dynamic. Basically, static is telling you the fluid status, and dynamic is telling you the fluid responsiveness. Static basically does not have any lung-heart interaction, whereas a dynamic would have a heart-lung interaction, and that makes me divide my tools into static, which is CVP, PA catheter, and the PICO at times. Dynamic would be a stroke volume variation, pulse pressure variation, 2D echo, PLR, and so on and so forth. You can also look at the microcirculation by doing an OPS technique under the tongue, and this is how it would look in sepsis. And then finally, my friends, whichever, it's like the five men, blind men and the elephant, whatever you touch, you might actually think that is the best or it is something else. And use the right tool and ask the right question is as what I told you all earlier. This is only for adults here. If there are any less than 18, you can go out. And it depends upon where you look and what you look for, and therefore please interpret very, very appropriately. If you didn't get it, it's okay. So in summary, my friends, a monitoring technique is similar to surgery. The tool is not as important as the operator skills, and hence you should know your tool well. Thank you. You all had mentioned for 2-3 MCQs, so very quickly in 10 seconds we can do this. Which of the following is allowed? Which of the following is not a dynamic parameter? A, B, C, D, E. D, everyone agrees? My God, that was really quick. For want of time, I think. The low SC, this is a little tougher. The low SCVO2, the mixed venous saturation, depicts which of the following? No. So basically cardiogenic shock. So lower the DO2, lower the SCVO2. And laughing Buddha depicts which shock? Cardiogenic. Excellent. Thank you, friends.
Heart failure with preserved ejection fraction is a new, more logical, more scientific, more inclusive term for something which was known as diastolic heart failure in olden days. So still there may be an element of diastolic heart failure, but then this will broadly include a lot of things. A very important point when we talk about heart failure, most of the physicians have a concept that ejection fraction is 15%, 20%, 30%. So you need to de-link the situation or a complex syndrome of heart failure from the ejection fraction, because it can be there with any ejection fraction. Now in ICUs, when you see patients, there can be few patients of HFpEF, heart failure with preserved EF, who are just HFpEF and do not have any other things. Or sometimes there are your patients who are critically ill and there may be associated HFpEF. So it's very, very important to understand that there can be some patients who are purely HFpEF. You may be thinking on so many terms because patients of HFpEF have got a lot of comorbid conditions like CKD, obstructive sleep apneas, liver disease, etc., obesity, diabetes. And sometimes you have got some other diagnosis, but HFpEF may coexist. So in next 10-12 minutes, I'm very sure we'll be able to get some idea into how to suspect and diagnose this condition. So here is a patient who has been seen by your registrar in ICU. Why do I say registrar? Because if some mistakes are made, they can be allowed. So a registrar has seen the patient and he is giving you input on phone call that this is a lady of 70 years, history of increasing fatigue and dyspnea for last 15 days, has cough, cold and some feverish feeling for last 2 days. NYHA class 3 to 4 dyspnea, so dyspnea has increased and now she believes even with minimal exertion or even at rest gets dyspneic. She is obese with BMI of 31 kg, pulse rate is 92 per minute but it is irregular. Blood pressure is quite okay, distended neck veins, basal lung crepitations, no murmur and there is minimal ankle edema. Patient has got past history of hypertension and diabetes for 10 years for which she has been taking regular treatment in terms of amlodipine, losartan, glimepiride, metformin, aspirin, statin, but there is no past history of IHD. She says, I never had any kind of sort of angina or angiography, etc. She has been a non-case of CKD with eGFR of 48 ml. So registrar has, based on this history and examination, rightly has done certain steps that given IV Lasix, has given nebulizer to the patient. Patient has been put on oxygen inhalations and now with oxygen inhalations 4 liters per minute, saturation is 98. By this time some investigations are available. Hemoglobin is 10.5, total count is slightly elevated, platelet count is 1.78, ECG is documented atrial fibrillation with control heart rate of 92. Creatinine is 1.28, urea is 28, sodium potassium reasonably okay, SGPT little up, serum protein normal, ABG is okay, urine routine micro is okay. And your registrar is also quite smart, has said that I have already asked for chest x-ray, echocardiography, HS troponin and NT-proBNP have been sent and awaited. So this is how I think I'm very sure registrar has elicited proper history, has seen the patient well and has also ordered the investigations. Now if this patient is put to you and if you do not know that this is a talk of a specific topic, then generally we are guided to think on so many differential diagnoses. It can be cardiac condition, heart failure or rheumatic heart disease, MS, MR, cardiomyopathy. It can be variety of pulmonary conditions. It can be sometimes severe renal and liver disease. And many times it can be a combo of so many things. Say we do see such patients who have got multiple things all contributing to some extent. Say for example, she has been on amlodipine. So some edema can happen with amlodipine. Luckily she was not on pioglitazone, but even some edema can happen with pioglitazone. Some anemia, aging, some CKD, all these things come together to produce something called as minimal edema, some fluid overload and some sort of dyspnea. So this is a very vast topic where most of the times at moment one we are never clear what the diagnosis is. So before we go further into the case, let me give you an idea about what is the definition of heart failure. Now heart failure definition does not involve ejection fraction. So that's something which is very important. It is basically conglomeration of signs and symptoms of heart failure which are produced because of either functional abnormality of heart or structural abnormality of heart. So what are the signs and symptoms? All those traditionally olds we know, paroxysmal nocturnal dyspnea, neck veins, crepitations, cardiomegaly, edema, etc., etc. But these signs and symptoms which are because of structural or functional impairment should be corroborated by one of the two, which is compulsory, either elevated natriuretic peptide or there has to be an echocardiography evidence that congestion is because of the heart. So heart failure based on echo is divided into multiple types which you know, HFrEF, that is something which is ejection fraction is less than 40%. So patient has heart failure, signs and symptoms, but EF is less than 40. And those who have got EF more than 50% and still having symptoms and signs of heart failure, they can be called as heart failure with preserved ejection fraction, HFpEF. But then when ejection fraction is more than 50%, signs and symptoms of heart failure are there, you need to have certain other evidences on echo to say that that patient has got heart failure. Now something about heart failure, and this is very grave, is if you look to the world scenario, out of all patients who are admitted with heart failure, more and more patients are now HFpEF. In USA, if you go look the trend, 50% patients who are admitted with heart failure are HFpEF. and not HFrEF. In India also, the incidence is increasing, but it is in the tune of 10 to 15%. But I'm very sure as the time goes up, because of variety of reasons, the things will go up. Very important point, and which is not pursued by most of the physicians. Once a patient has been diagnosed with heart failure, whether HFrEF or HFpEF, the prognosis is same. And that is something which is so alarming. Somebody who has heart failure, ejection fraction is 55, most of the times physician would say that kuch nahi, to theek hai, pumping normal hai. The prognosis is same. If your HFrEF patient is going to live for 5 years, then HFpEF patient is also going to live for 5 years. So this is a grave situation where not only the patient, but even clinician or treating physician is in sort of Shangri-La, false sense of security that things are fine. And a very important point which we will discuss, even there are no as great medicines available for HFpEF as they are available for HFrEF. Now a very important point as far as HFpEF is concerned, the HFrEF, if you look, the cardiovascular disease is the more cause of mortality, while if you look to the HFpEF, known cardiovascular causes of mortality are more. So meaning to say that HFpEF is a syndrome where most of the times heart is a bystander. There is something going on wrong in the body, in the kidneys, in the livers, in the vascular structures, anywhere else, but which is causing heart to undergo damage. So in many such cases, heart is a bystander, and that is what is the beauty of the situation. What is the basic pathophysiology? I won't go into the details, but if you look to the right hand here, HFrEF, generally chambers are stretched and thinned out myocardium, while HFpEF, generally chambers are smaller, but the myocardium is stiff. So basically it is remodeling of the myocardium with increased stiffness. And what happens if you look to the left lower, generally when the diastole, the ventricle fills easily to a good volume without much increase in ventricular pressure. But in HFpEF, what happens if the ventricle starts getting filled with even minimal filling, the pressure disproportionately goes high. So what does it mean? There is either inadequate filling of ventricle, or even if there is adequate filling, but it is at a penalty of much elevated diastolic pressure. So this is the hallmark as far as pathophysiology is concerned. So how it goes? Lot of comorbid conditions like obesity, diabetes, hypertension, they all produce something called as systemic inflammation. So mind well, HFpEF is by and large a condition where there is profound systemic inflammation is there. Echo is, as I talked to you, is very useful. There are certain echo findings which help us to diagnose HFpEF. So how to diagnose HFpEF? There is a scoring system which is, as the name suggests, HFpEF. What are those points? Heavy. If your BMI is more than 30, you get 2 marks. If you are hypertensive with 2 or more medicines, so little resistant type of hypertension, you get 1 marks. Atrial fibrillation, either paroxysmal or persistence, even one episode of atrial fibrillation is there, it gives the 3 marks. Pulmonary hypertension picked up by echo gets you 1 mark, age more than 60 years get you 1 mark, and elevated filling pressure, which suggests that, as I discussed, the ventricles are getting filled, but with filling the pressure goes up. That is also can be picked up by echo. So if it is there, there is 1 mark. So there are total 9 marks, and if a patient is getting 6 or more marks, it is very likely that this patient is HFpEF. So in every such patients which I am discussing, some edema, some dyspnea, you have to just pass through the patient through this HFpEF score. Reasonably easy, because I'm very sure all such patients will do get echo, but your echocardiographer, cardiologists or technicians must be asked to look for LA volume and LA dilatation, LVH and LV mass, and evidences of elevated diastolic filling pressure. Then only you can put this to the perspective. So coming to kind of treatment in next 2 to 3 minutes, generally, when you think of HFpEF, you have to also put lot of differential diagnosis, treat the comorbid conditions. That has been the rule so far, because there was perhaps no treatment available till now, and decongest the patient. Give the diuretics, but mind well, not exaggerated diuretics. Because if you give too much dose of diuretics, the preload will reduce, and in patients of HFpEF or diastolic heart failure, cardiac output is quite preload dependent. So if you reduce drastically volume, then patient will go to short acute kidney injury, 1 or 2 minutes more. So in this cases, you have to be cautiously giving diuretics. The moment you believe that now congestion is out, you have to reduce the dose, and perhaps you might have to take off also. Now there are 2 medicines which have emerged in last 2 to 3 years, which can be used for HFpEF. They reduce the composite endpoint. When you look at any patient of heart failure, your purpose is a patient has to live longer by reducing mortality, and patient should not getting readmission recurrently, because these are 2 very important points. So one drug which is available is ARNI, valsartan sacubitril combination, which is very well available, and that helps the patient who is in a HFpEF. And second drug which is become blockbuster, that is SGLT2 inhibitors. These are the drugs also where either use dapagliflozin 10 milligram or empagliflozin 10 milligram. When treatment of diabetes is concerned, the dose of EMPA can go to 25, but for HFpEF, both the drugs, EMPA or DAPA, should be used at 10 milligram. So if you look to your patient, you know the history. X-ray is available by this time, there is congestion, cardiomegaly, NT-proBNP is high, and on echo, you are getting left atrial volume overload, left ventricular hypertrophy, and there are evidences of diastolic dysfunction. So this patient has got almost all the features of HFpEF, all the features. If I have just highlighted them, age is more than 70 years, AF is there, obesity is there, patient is resistant hypertensive, ECG suggests of AF, and there are evidences. So this patient goes for HFpEF. Carry home messages for this lecture. HFpEF is a very vitally important condition seen in many patients in ICU and also few patients in OPD base. Mortality in patients of HFpEF is as great and as worse as HFrEF. They have poor quality of life and very poor exercise tolerance. So they are very seriously ill. Basically, it is a systemic inflammation because of multiple comorbid conditions. The treatment are diuretics in a small dose to be tapered off and maybe switched off. ARNI and SGLT2 inhibitors are the drugs which have to be there in every patient where you diagnose HFpEF. And this is a vast area where so many things we as scientists, as cardiologists, as clinicians don't know, and future will tell us much better about that. Thank you very much for your attention.
I'm going to talk about the 10 commandments for successful antibiotic practices, totally controversial, I'm sure, much more than the PA catheter. And as we stand here, what are the principles I would actually like using? So my disclaimer before I start is that I'm not gonna preach like the commandments of Moses, but I'm only going to share my expertise along the way as Dr. KB. So forget Moses here, sorry, no harm intended. And I thought this cartoon looked like me, so let's begin. So commandment number 1, thou shalt not treat every fever with antibiotics. Extremely important because there are many infections that may not have fever, and fever is not equal to infection. So patients who have immunocompromised state on steroids, CRF, elderly patients, patients with fungal infection may not even have fever, and here you need to start antibiotics. As against that, there's a big list of non-infectious causes of fever that could be central, drug, thyroiditis, pancreatitis, embolisms, malignancies, vasculitis, and so on and so forth. Second commandment is, thou shalt differentiate virulence from resistance. Sorry for this diagram again, but you need to understand that a common example is cellulitis. Cellulitis basically can be caused by Pseudomonas, can be caused by a very resistant organism, but the patient may have foul smelling, even maggots coming out, but they can be walking around for months together with the cellulitis. As against that, a necrotizing fasciitis is caused by strep pyogens, which only needs penicillin or ceftriaxone, so it's not a resistant organism, but it is extremely virulent and it can eat up an arm within 1 day, and it can cause death within 24 to 48 hours unless police hai jiske haath lambe hai. Commandment number 3, thou shalt know your patient. So every antibiotic is not same for every patient, and here you need to understand the difference. Whether the person is competent, incompetent, I mean not the doctor also, but the patient, whether there is a competent host or an incompetent host. We know that a competent host would probably present with meningitis and fasciitis and bloodstream infections, but an immunocompromised host is not always an HIV patient. It could be a splenectomized patient where you have encapsulated bacteria. It could be anything else where there is diabetes and now even post-COVID. So you need to know your host very well. Commandment number 4, thou shalt use non-antibiotic strategies whenever possible and always possible, which is hand washing, source control, and the bundle funda as I put it. So in India, hand washing is better than washing feet. Actually, in India, we have a tendency of washing feet of our elders, but that way, I think you are 15 years and I'm 29 years, so in the field. Just kidding. But I still feel that in the ICU, we should only wash our hands and not the feet. Device removal. This is a very nice diagram which actually shows that you have a central line in place. Within 4 hours, there is almost no biofilm. But within 18 hours, 16 to 18 hours, it is filled with biofilm. How will your antibiotic ever reach there? How will you manage this biofilm penetration, even for fungal infections, etc.? So it's extremely important for us to know that a device which is infected needs to come out. And we use great antibiotics. Which is the best and the most expensive antibiotic in the world? Most expensive antibiotic? Meropenem. The antibiotic which does not work because it costs a life. So I feel that is the most expensive antibiotic. And therefore you might use a gorillamycin, you might give it whatever name, but finally you need to source control. Now would you tell me which is a worse scenario, the upper one or the lower one? The upper one, because there is no fasciitis done. Bundle fundas, we love bundles, and bundle marne ko chance mila mujhe. A, B, C, D, E, the WAP bundle, the central line, but follow it as a bundle of practices which are evidence based and they have made a difference. Otherwise it's just a time pass on the paper. And these are all the bundles that we practice. Commandment 5, thou shalt know local epidemiology and antibiograms. So you should know your hospital, you should know your patient, you should know your antibiograms. And in Hinduja at least we know which are the bugs, and we have a list coming up, and you should know your spice and your escape organisms. Commandment number 6, thou shalt use your PKPDs extremely well to help you. Dose right, duration should be adequate, and there is something called as augmented renal clearance. Excuse me. So when we talk of pharmacodynamics, there are antibiotics which we need to make a right choice. If we are looking at the AUC above the MIC, then probably we are talking about colistin. If we are looking at the peak above MIC, then it becomes concentration dependent, and here we would be looking at the aminoglycosides and the daptomycin. If we are looking time above MIC, then it becomes the time dependent, and here most of our antibiotics like beta-lactams, clindamycin, clarithromycin would come in. And then there is something called as concentration dependent with time dependence. Everything keeps merging, and those are also important. You also need to know whether your antibiotic is hydrophilic or lipophilic. Then is a very important thing, and how many nephrologists in the audience besides the CRRT? He left, thank God. So I never know. I love my nephrology colleagues, but I would never send a patient to a nephrology consult for the first 3 to 5 days unless I really need a CRRT which I can't perform or a SLED which I can't perform. Because the first thing they do is they cut down the antibiotic doses. And if the AKI is setting in, because of the sepsis, it is imperative for us to treat the patient with the right antibiotic, so everyone might guess, but treat it with the right dose. And this was a very nice study in which they showed that augmented renal clearance actually happens in sepsis, where you need to use much higher doses, and this is compounded by so much of renal reserve, tubular functions, increased cardiac index, the hyper state, hyperanabolic state, and so on and so forth. Commandment number 7, thou shalt de-escalate appropriately. Now de-escalation is very, very nicely told on the stage here, never done in the ICU. If the person is 5 days getting better, मैं change करूँगा, वापस worse हो गया तो मेरी लग जाएगी 2 और दिन दो. Also the first day we are Baba Ramdev products. First day we write day 1 by Piptaz or Meropenem, day 1 by 8. How can you predict that he needs 8 days? Why not stop at 3 days? Why not 5? And why always 5 or 8? Why not 6, 7? So it's very funny. So it's very important for us to understand when to use and how to use and de-escalate appropriately. And there is enough literature which says that de-escalation actually helps. You might switch to a smaller or a lesser, narrower spectrum, and I'll come to that in my 10th, whatever it's called, commandment. So commandment 8 is thou shalt deliver antibiotics locally, not that we import it from US and use it in Ahmedabad. What I mean by locally is that you could use it at the site. So you could, now orthopedics are infiltrating beads of vancomycin and even levonadifloxacin in the joints. Similarly, we in intensive care, not in cardiac surgery, use we use intrathecal and we use nebulization. So if there is a lung issue, if there's a lung issue, we use nebulizations preemptively. And when you use the nebulizations, you need to know which kind of nebulizer you are using. That could be ultrasonic, that could be jet, that could be vibrating mesh, which is expensive, but this is extremely important. Intrathecal, many a times we've used, and we can use Vanc, colistin and polymyxin sometimes, and these are the antibiotics which we can use intrathecally as well. Commandment number 9, thou shalt use rapid diagnostics and targeted therapy. I think this is the most important for us in the next few years, and we need to understand what we are dealing with. You can't just be giving broad spectrum antibiotics all your life and hoping that it works. And many a times when patients are referred to us as a tertiary center, they are already on 5 antibiotics and 3 antifungals, and our job is actually to try and stop that and rationalize things. So I don't think giving every possible antibiotic just because we have not taken, been better over the organism means good. So we can have the matrix assisted laser desorption, MALDI-TOF and ionization, or we could have an expert CABA now. So we follow the expert CABA and it actually tells you everything about if it is a CRE, is it KPC, NDM, CTXM, OXA48, and then you can decide your antibiotics, and this result can be obtained extremely fast. Expert CABA or blood culture ID can be done only after the blood culture is positive, but there are newer technologies which even don't wait for that and give you an answer in 4 hours, and they don't only tell you it's Pseudomonas or Acinetto or it is staph, but it tells you the gene, the MEK gene or whatever, and therefore you can decide. So I think this is one of the most important way forward. Earlier, we are all as intensivists thought to be fast and furious. Appropriate antibiotics was meant to be the old paradigm where treating broad and then de-escalating, what I told you till now. But the new paradigm, anybody? New paradigm is always pathogen-directed therapy, and therefore it needs the newer diagnostics. Commandment 10, thou shalt always use the right R's as part of your antibiotic stewardship. So I would use the right drug, that is an ESBL, CRE, what am I covering? I would use the right dose, looking at the augmented renal clearance. I would use the right duration. 7 days is probably better by a lot of literature than 14 days. Right, unless it is endocarditis or some special meningitis or osteomyelitis. Right delivery, I can use a prolonged infusion to try and keep my timing above the MIC higher. I could do local delivery in forms of intrathecal or nebulization. I could rightly de-escalate because we know that there are better outcomes. I would use the right combination, especially for CRE, especially for Acinetobacter, we can add a sulbactam and so on and so forth. And then we would use the right penetration, don't get me wrong here, use the right PK/PD formula. So hydrophilic or lipophilic, and we need to actually understand what is important. Is it a hepatic excretion? Is it a renal excretion? Is it tissue bound? Is it protein bound? And so on and so forth. So have we reached, one more minute. Have we reached the end of the road? Anybody? No. So many new roads I saw in Ahmedabad when I was coming late night. Just need to take a turn, and clap for the gentleman for saying that. Just need to take a turn at the bend. We have not reached the end. And please, please, as intensivists, as physicians, as doctors, never ever give up. If I may end here, the 10 commandments in the ICU are the follows. This is just taken from the net. Secure your ABCs. consider giving naloxone, glucose and thiamine to everybody who's unconscious in your ER. Get a pregnancy test appropriately. Assume the worst, rule out serious disease. No, I don't want you all to quote me after 5 days saying that. And Mill mere naam se fadega, bolega khushaw ko jaake pucha. Do not send unstable patients to radiology. Extremely important in trauma. Look for the common red flags everywhere. Except in China. Trust no one and believe nothing. Please, the first thing is to doubt yourself. Am I wrong? A very, very nice talk on intubation. Haven't you heard in the ICU, oh, intubation was so difficult. Why was it difficult? Because I didn't know how to do it. So, no malampati is told to you, no nothing is told to you. Why? It was very difficult. Why? I tried 3 times, but brain dead ho gaya. So it's very uncommon for us to doubt ourselves. If you put a Riles tube and if you hear the bowel sounds, you will always hear it, no matter whether it's in the rectum or it's in the trachea. But if somebody, your colleague has put a Riles tube and you are, or push karo, I don't think it is right. We have this tendency in life to always believe we are the best and believe that others are wrong. So please trust nobody, including yourself. Learn from your mistakes, and that is called as the servo mechanism, not the ventilator. It actually, we have to learn and relearn. Yeah, done. Do unto others as you would do unto your family. Very, very important in life. I think you must treat every patient with dignity and with compassion and then come to the right thing. And also your co-workers, please. Either you come to me, to jidhar se aaya wo to ekdam bekar doctor hai. When in doubt, err on the side of the patient and you will always be covered well. And nowadays, everything, my voice, my height, my obesity, everything is blamed on COVID. Arre, COVID ke baad mera ye sab ho gaya. Waise hi every patient, every disease is blamed on COVID, so stop doing that. Thank you. Just half a minute. Which of these conditions require antibiotics? Yeah, none of the others, that's more important. Which of the following sentences is false? Thoda tricky hai. Pharmacokinetics is the movement of the drugs through the body. Dynamics is body's biological response to the drugs. Right or no? Yes. AUC are good terms. Protein binding is PK parameter or PD parameter. Either hi catch hai. So PD is the wrong one, it is a PK parameter. When you talk of pharmacodynamics, we are talking of metabolism, excretion, distribution. Last one. The commonest CR in India are all except KPC, exactly. So less than 5 to 7%. Thank you, friends.
I'm telling you invasive fungal infections in ICU, diagnosis and management. Now, as an intensivist, the life is very difficult when it comes to fungal infection. We are very well tuned to bacterial infections, gram positive, gram negatives. But if you look at the profile of patients coming to ICU, very rarely would you see a patient coming in ICU with a fungal sepsis. They normally develop it during the course of their critical illness, having been neutropenic or non-neutropenic. And it is extremely difficult for us to differentiate that deterioration from a bacterial versus a fungal. And that is where we are going to target this talk, that how do we really diagnose? And for diagnosis, our job is made even more difficult. Why? Because most of the cultures that grow fungus would take 3 to 5 days. And further species identification or maybe the sensitivities take another 2 days. So by the time you get something from the lab, your patient is either better or dead. So most of the time it is empirical antifungal therapy. And as I was told to have a case, so we start with the case. This is a case right now we have in ICU, a fresh case. So he is a middle-aged male who's got comorbidities, diabetes, hypertension, chronic liver disease. He came to us with 5 days history of pain abdomen with constipation and vomiting and respiratory distress for 1 day along with fever. Coming to us, he was lethargic, borderline blood pressure, tachycardia, little one saturation and febrile. His abdomen was distended, diffusely tender, and auscultation we could get diffuse crepes all over, and at the basis the entry was decreased. His blood investigations were remarkable for having neutrophilic leukocytosis, a deranged renal function with a creatinine of 3.6 and deranged hepatic functions, both bilirubin and the transaminases. The CT abdomen we did, a non-contrast, showed us that there's a gut malrotation at the level of duodenum-jejunum junction and proximal loop dilatation. And the surgical intervention was that unwinded. Now, I won't tell you about the surgery, not my area. For the first week that he was in ICU, he was put on broad spectrum antibiotics, a BL-BLI combination. We put in a central line, gave him TPN, and his renal functions over the first week deranged to a point we had to dialyze him. So he had a catheter with an ongoing intermittent dialysis. Day 8, after the first week of his being in the ICU, he developed fever. And not just fever, within 12 hours, he became hemodynamically unstable with a rising lactate and a deteriorating hemodynamic profile. At this point in time, we could document that he's not just got low pressure, but he's in shock. So BP and shock may not go together. You may have a low BP, still not be in shock. So he had a rising lactate and a poor capillary refill time. His X-ray, blood gas, saturation did not markedly worsen, the tracheal secretion did not markedly worsen, just to harvest the point that we did not have any evidence of VAP or any LRTI as a possible culprit to this deterioration. We did an ultrasound abdomen, that is what we could do bedside, and we did not find anything fancy, no new collections and mild ascites. But we did find a rash over the chest. It looked like this. Okay, just have a very careful look at the rash. These are pustules with possibly some erythematous base. You can appreciate that, all of you? Okay. Now, my question to you is, this deterioration after a week, what could it be? What are your diagnoses? So he is in shock after 1 week. Is it septic or any other differentials? Could it be embolism after a week? Possibly, if we did not give him prophylaxis. Could it be stress cardiomyopathy? Could be. We did not tell you the echo. So for the purpose of this presentation, let us assume all was done, was good, and this was possibly a septic deterioration to the patient after 1 week of ICU, TPN, dialysis and broad spectrum antibiotics. So at this point in time, what would you be doing after sending cultures? What would be antimicrobial coverage empirically done? You have nothing to guide you except the clinical scenario and the risk factors I gave you. How many of you would step from a BL-BLI to meropenem? Would you? Okay. Some of us, some of them are shy. How many would you add a gram-positive in a form of MRSA cover to this patient? Only a couple of them. Why would everybody else is not very keen on MRSA cover? Because it really depends how much MRSA you normally see in your ICU. If your MRSA is less than 5%, maybe you get away without giving empirical MRSA coverage. Okay. How many of you would be at this point keen in adding an antifungal cover? Only one. My presentation is not fungus. There should be more people. Okay. So at this point in time, there are factors where they would tell you that this patient might have a fungal flare, and I will tell you in the next few slides why you should add an empirical antifungal cover, and then we'll discuss what coverage is required. So this is a bedside scoring system, very simple, everybody can use it. This is a Candida score, and we give a mark to the things that the patient has as risk factors. So 1 for TPN, 1 for surgery, in this case abdominal surgery, very high risk, multifocal colonization, 2 for clinical severe sepsis, this guy fits into severe sepsis, and a cutoff value of 2.5 gives you a good sensitivity of around 81%. And in this case, the score is around 4. If the score of Candida is taken as 3.5 instead of 2.5, the sensitivity and the specificity further markedly goes up. Okay, with the score of 4, I am okay to give this patient empirical antifungal coverage. Why? Because if I miss on the fungus now, even when you treat Candida in ICU, in a stable patient, the mortality is between 40 to 60% after having given timely, appropriate antifungal. So imagine what happens if you miss in a septic shock fungus. The mortality goes more than 90%. That means almost a sure chance this guy would die if you missed on the antifungals. Okay. So cultures, 24 hour, 48 hour sterile, no help. We did a beta D glucan. This is high. From the cutoff, almost 2 times the cutoff, a very high beta D glucan. What does beta D glucan tell us? There's a possibility of a fungus, not specific to Candida, because it's a cell wall thing. Every fungus has beta D glucan, but tells you that there's a chance that this guy may have fungus, and this is a rapid test. So if you have it on site, maybe the same day later in the evening, you would get a beta D glucan report. You don't have to wait 7 days like a culture. And respond rapidly to antimicrobials because we gave him a ESBL coverage and we added an antifungal. What we added, we'll discuss. Okay. So, treatment of invasive candidiasis starts with risk factor assessment because 99.999% of your antifungal usage in your ICU would be empirical. If you're very lucky, you might have a culture to support. A lot of time you find a tracheal culture telling you aspergillus. You know it's a colonizer, you don't know it's an invasive fungus, and you end up treating the patients. If you don't have any evidence of invasive aspergillus, why would you treat it? Right? So a lot of time even the cultures being positive do not help. They have to be put in a clinical context. Okay. When do you suspect? Risk factors. What risk factors? If you got a patient who's in ICU with lines, on dialysis, receiving parenteral nutrition, having had surgery, especially high risk abdominal surgery, and to make the things worse, if the patient is neutropenic and has received prolonged high dose steroids. So all of these risk factors markedly increase the chances of fungus. Okay. And where does the fungus normally come from? Where does the candida normally come from? For non-neutropenic patients is the lines, and for neutropenic patients is mostly the translocating from the gut. Okay. Clinical features with risk factors in a patient who's got new onset fever, septic deterioration, along with look at the skin, very important. We picked up candida in this patient by looking at the skin rash. That was a classical candida skin rash. Look at the fundus, look at the echo. You do echo routinely in any patient, right? You see for deterioration. Why don't you look at the valve, see if there's any vegetation to tell you there's a seeding there, and any other organ involvement. By that I mean, if you have a patient who's got in the last week candida in the urine, candida from the tracheal secretions, candida from one more sterile site, all of these are telling you that this guy has got increasing chances of having candida sepsis. So having colonization from more than 2 sites, again a risk factor to tell you that this guy may have or may develop invasive candidiasis. Okay. Now this is another photo. This is not a patient. So you can see the pustules with the erythematous base, and you may see these large nodules. At times the sister comes, there's a new rash to the patient. Look at this rash. So you will find very often if you look for it. So these are large nodules with necrotic center and an erythematous base. And most of the time you find them on the flank, on the back. Skin lesions, if you scrape them, so I'll take 2 minutes. If you scrape them, you might send them for stain. You might find a muscle abscess for showing disseminated candidiasis, again a spleen or a kidney specimen showing that, and a fundus examination. Now how do you diagnose? You diagnose by culture methods and non-culture methods. Now I'll go fast. Cultures, you understand, these are the methods. You can use Malditop if you have it, you may use PNA fish to decrease the time to get a positive culture. With PNA fish, a positive culture, 4 hours later you know what is the candida. With Malditop, you have a positive culture, 30 to 60 minutes later you know what is a fungus. If you look at the non-culture methods, it depends on-site, off-site, turnaround time 24 hours. The good thing about non-culture methods is that they have a very high negative predictive value. So let's say you have a blood culture negative and a beta D glucan negative, or a blood culture negative along with a PCR negative. It is almost sure that this patient doesn't have candida, and you can stop the empirical antifungal coverage. Okay, so very important. You combine culture with one of these methods, maybe beta D glucan and PCR, and between the two, PCR and blood culture are a better combination than a beta D glucan and a blood culture. Now, how do you treat these patients? Differentiate on 2 parts: neutropenic, non-neutropenic, hemodynamically stable, unstable. The choices are the same. What you have is echinocandidins, azoles, and polyenes. So, empirically in this patient, what should I have used? Fluconazole or echinocandidine? Echinocandidine. Why is that? Because of? So fluconazole covers candida very well, and your answer is correct. In a hemodynamically unstable patient, never use azoles. Always use echinocandidines, right? 1. Can you use fluconazole in any patient in ICU? Yes, in a very small subset. If the patient has no prior azole exposure, your incidence of azole resistance is less than 5%, and the patient has to be stable, non-neutropenic. Otherwise, you cannot use fluconazole, for that matter, any azole in the ICU. And just one more slide. In neutropenic patient, what I wanted to highlight is that, of course, you should not be using fluconazole, more chances of using gynocaridines. In case of neutropenia, the duration of therapy is much longer. For how much long do you think in my patient I should have given antifungals? 1 week, 2 weeks, 3 weeks, 4 weeks, 6 weeks? 6 days? 6 weeks. Okay. Anybody else? So normally the dictum is from the last negative culture, 14 days. So how often do you send cultures? You send a culture, you start your antifungal. If you're very rich, everyday blood cultures. If you're not so rich, I start doing cultures from day 4. Day 4 से पहले negative नहीं होता. I do it alternate day. If I have a culture negative from that day, 14 days. If I have a seeding in the eye, liver, kidney, my duration becomes 6 weeks, so maybe longer. Right? So disseminated invasive candidiasis could be just the blood or blood and organ. If it's an organ, eye, kidney, anywhere, the duration is much longer. As I said, it is 6 weeks. Right? Thank you very much for your patience.
Good afternoon, everyone. Though this topic needs an entire conference in itself, I will try to cover the cardinal points. So, the care of polytrauma patient does not end in the operating room or the ER. The patient presenting is really far from stable with the ongoing hemorrhage, resuscitation needs, and injury that still require a definitive repair. So coming to a case, so we have a 25-year-old male polytrauma patient who was shifted from ER to the intensive care unit after initial resuscitation, left ICD insertion and intubation. The mechanism of RTA is very important. So this patient was a pedestrian hit by a speeding four-wheeler. So on initial presentation, his vitals were, he had tachycardia, heart rate 145 per minute, BP of 100/50, saturation on room air 90%, and he was tachypneic. So he was found to have a low Glasgow Coma scale, E2, M3 and V2. He was intubated and sedated in the ER. So his injuries included a large left pneumothorax, a grade 1 splenic laceration without extravasation of contrast, so right frontotemporoparietal hematoma with no significant mass effect, and he had open tibial fracture. So now coming to this patient, the multidisciplinary coordination of care plan is pivotal to his survival. So now he was shifted to the ICU. So once the patient is shifted to the ICU, now the cardinal job of the intensivist remains to complete the tertiary evaluation, look, listen and feel for any of the missed injuries that increases the mortality. Now this patient, despite adequate pain relief and sedation, he remains to have tachypnea and increased oxygen requirements. He was afebrile with no petechial rashes. Chest wall excursions were normal and the AL3 was bilaterally equal. Initial blood investigation showed no thrombocytopenia, and left ICD was draining about 50 ml per hour of blood with small airly. So EFAS, the point of care lung USG, shows the following. So we can see few B lines here. And HRCT chest after initial stabilization shows these non-segmental airspace opacities, mostly in the peripheries, right? So any guesses what could be the cause of the tachypnea? Anyone? So yeah, it's a pulmonary contusion. Okay. So pulmonary contusions are common in the adult trauma patient with multiple rib fractures, and they increases the mortality more than 25%. So what to do when the patient is having pulmonary contusion? You just maintain euvolemia, do not overflood the patient. It will further decrease your PF ratios. Adequate sedation and analgesia is required. It could be both systemic and local. And lung protective ventilation once the ARDS sets in. Carries a very bad prognosis. So as I said, you have to look for any missed injuries. So what could be the other cause of tachypnea in these patients? So this patient, had we not first inserted an ICD and just put our endotracheal tube first, so because of the positive pressure ventilation, we could get a tension pneumothorax. So this patient may have a hemothorax. So quantification of blood per hour is important. If the patient has drained immediately 1500 ml of blood on insertion of ICD or more than 200 ml of blood per hour, so we need an operative intervention. So there could be a blunt cardiac injury and a major vessel blunt injury. So always look for the chest wall excursions and look for the flail chest and traumatic diaphragmatic rupture. One thing we often forget, always keep a high level of suspicion, high index of suspicion of fat embolism syndrome in patient with uncorrected long bone fractures. So now the patient is noted to have ongoing oozing from the fractured tibia site. He is hemodynamically although stable. He is having coagulopathy and hypothermia. He is warm aggressively. He continues to receive plasma and tranexamic acid. So what is the next step? Should we go for a definitive fracture repair right now? Or should we just do an external fixation with the debridement or irrigation of the wound? Shall we do nothing, just conservative management, or none of the options hold true? Anybody here? Yes, we'll go for the external fixation with the irrigation of the wound. So now the patient has undergone damage control orthopedics, damage control surgery. So the patient was in the lethal triad. So what is lethal triad? It is acidosis, coagulopathy and hypothermia, right? So how to combat the lethal triad? You need to have a damage control strategy, which includes permissive hypotension, hemostatic resuscitation. You treat the coagulopathy and you control the damage. So hypotensive resuscitation, it is controlled hypotension of MAP of around 65. You prevent the dislodgement of clots. So you target the systolic BP of around 80 to 100 mm of Hg. So you do it patients without traumatic brain injury, because with traumatic brain injury you will decrease the cerebral perfusion pressure. Okay. So now what is trauma-induced coagulopathy? This sets in within 30 minutes of the trauma and it's present up to 30% of the cases. With extreme sympathoadrenal activation and use of initial resuscitation, so there is endothelial glycocalus disruption, which leads to multiple activation of the coagulation pathways and fibrinolysis along with dilutional coagulopathy. So in this case, the viscoelastic test, the point of care coagulation profile testing, TEG and ROTEM are of great use because they provide a better pathological insight into this. So use of blood products as indicated by the coagulation studies is imperative to the management of trauma-induced coagulopathy. And now what is hemostatic resuscitation? So we use the blood product early after the initial crystalloid bolus. It is the combination of the blood products in the balanced ratio, 1:1:1 ratio. So there are several predictive models. So if we have a patient with high MBT score, early and aggressive use of blood components is indicated. And as I said, in the ratio of 1:1:1. So now what is the damage control surgery? The damage control surgery does not focus on the anatomical repair, it's rather the physiological repair. Okay, so this is the bleeding control, quick decontaminations of the body and planned reoperation as soon as possible, as soon as the patient's physiology is better. So now coming to the antibiotic coverage in the trauma patient. So is it recommended in all the patients? So it is recommended with those patients with open fractures, open head injuries, penetrating thoracic injuries, hollow viscous injury and a chest tube placement. So you have to prevent soft tissue infections. So the debridement and irrigation should ideally be done within 24 hours. Antibiotic prophylaxis, you need to cover MSSA and coagulase negative Staph aureus. So additional gram-negative and anaerobic coverage for type 2 and type 3 open fractures with skin laceration greater than 1 centimeters and greater than 10 centimeters. So now coming back to our case, 48 hours later, the patient's GCS worsens to no eye opening, decerebration to deep pain stimulus and sluggishly reacting unequal pupil. So he is coning actually. So he is now noted to have bradycardia and hypertension. So what are we supposed to do here? Hyperventilation as a temporizing measure and hyperosmolar therapy. Urgent shift to the OT, urgent shift to the CT. Do nothing, just trouble the neurosurgeon. Who is up for the last option? So yeah, so the answer here, anybody? The answer is hyperventilation as a temporizing measure and hyperosmolar therapy. The CT scan suggested expansion of right FTP hematoma with mass effect. Urgent decompression craniectomy was done and patient was shifted back to ICU with an EVD in situ. So the cardinal points in management of traumatic brain injury, it remains prevent the secondary brain injury, do no harm. So hyperventilation should be avoided in the first 24 hours because it decreases cerebral perfusion pressure because of vasospasm. It should be used as a temporizing measure only and the patient is found to be coning and herniating. Surgical evacuation is based on hematoma volume, mass effect and the neurological status. Not every patient is taken for a decompressive craniotomy. Severe TBI with mass effect ventriculostomy, ICP monitoring is suggested. So what are the anticipated complications in a polytrauma patient? So these complications are related to the specific patient injuries, resuscitative efforts, how much we have resuscitated, and prolonged mechanical ventilation and immobilization. As we all know, these patients cannot be mobilized very easily and early, and we cannot use thromboprophylaxis very early in the disease because of the risks for bleeding. So they are very prone for DVT and pulmonary embolism. So ARDS is more prevalent with the patients with high Apache score, presence of pulmonary contusion, those patients whom we massively transfuse, long bone fractures and flail chest. Transfusion associated complications are common in these patients. So ventilated associated pneumonia is found to be more prevalent in these patients, those who have undergone a pre-hospital intubation, blunt chest trauma and higher injury severity. Acute kidney injury is common with the patient receiving high amount of contrast, older patients, comorbidities, massive transfusion, and those you have used volume loaded with hydroxyethyl starch. So just the take-home message for the polytrauma patients are: trauma kills in predictable fashion. Multidisciplinary approach is pivotal to the survival of the patient. Complete the tertiary evaluation. Do not miss any injury. Address all the missed injuries. Combat the lethal triad. Follow the damage control strategy. Thank you so much.
So I'll be talking about the adrenal insufficiency in the ICU. So the case is a 56-year-old female patient complaining of weakness, tiredness and muscle pain for past 5 days and admitted with altered sensorium with no history of fever, headache, seizure, no past significant medical history, but patient is taking some alternative medications for knee pain for long past and has stopped for past 1 week. On examination, patient has been having hypotension with blood pressure of 90 by 60 mm mercury. With patient has clinical Cushingoid features are there, no systemic features. Primary investigation have shown serum creatinine of 1.8, sodium was low on lower side 134, normal potassium, lower sugar level RBS was 80, ABG shows metabolic acidosis and rest of the investigations were normal. So first of all, if patient is having, whenever we are suspecting adrenal insufficiency in ICU, what are the clues, clinical clues in this patient which suggest that this patient might be having adrenal insufficiency? So starting from patient has been using alternative medication for long, patient has clinical Cushingoid features with admitted with hypotension, hyponatremia, low blood sugar, metabolic acidosis. So these are some clinical features that suggest that patient might be having adrenal insufficiency. So these are the clinical features as I've already discussed: anorexia, weight loss, generalized weakness, GI symptoms including nausea, vomiting, myalgia, arthralgia, orthostatic hypotension. These are the common features. Hyponatremia is also common features. There are few clinical features on the basis of which you can decide that this patient having either primary adrenal insufficiency or a secondary adrenal insufficiency, and these are this. So hyperkalemia is common in primary adrenal insufficiency because of the mineralocorticoid deficiency. When patient is having secondary adrenal insufficiency due to defect at the pituitary level or hypothalamus level, the mineralocorticoid axis remains active and therefore the hyperkalemia is uncommon, similar to in our patient. The hyperpigmentation again is common in primary adrenal insufficiency because of the elevated ACTH, and which is not common in secondary adrenal insufficiency. What you may find in secondary adrenal insufficiency is the defect of the other pituitary hormones, maybe gonadotropes or the thyroxine deficiency can be found in patients who are having secondary adrenal insufficiency. So what should be the best confirmatory test when you are suspecting that this patient might be having adrenal insufficiency? So first we need to understand what is the cortisol, the HP axis physiology during the critical illness. So whenever there is an acute illness, there is increase in the stress response, and because of that the ACTH level, the cortisol level goes high. over a period of time in a subacute and the chronic state it stabilizes, and when the chronic stage ensues, there is a gradual decline in the cortisol level. So for the diagnosis in the for the adrenal insufficiency in the ICU is the random cortisol. We don't wait for the morning fasting cortisol, because during critical illness there is a significant increase in the cortisol level, as well as the normal diurnal variation of serum cortisol which is happening in the normal patient is lost, and therefore a random cortisol is sufficient. If a random cortisol level is less than 15 microgram per dl, it confirms the adrenal insufficiency. If it is more than 33, it rules out adrenal insufficiency. In between that, we need to do an ACTH stimulation test. Now, we are having that syntropin available with us. With 250 microgram, we can do the ACTH stimulation test, and if the delta rise is more than 9 microgram per deciliter, it rules out adrenal insufficiency. The delta rise less than 9, it confirms the adrenal insufficiency. So in our case, it was 8.2. That confirms it doesn't require any ACTH stimulation test, and we can directly go ahead for the treatment. What are the additional investigation which is required for the diagnosis? Maybe we can go for the ABG electrolyte. The ACTH is also very important to differentiate between the primary versus secondary. The plasma renin activity, aldosterone, will also help in differentiating primary versus secondary. The antibodies, if you suspect an autoimmune adrenal insufficiency, again 21 hydroxylase antibodies which are available. The imaging, depending on whether there is a primary adrenal insufficiency or a secondary adrenal insufficiency, we can go ahead with either CCT adrenal or the MRI cell. So there is a long list of etiology. The most common etiology for adrenal insufficiency in India is still the iatrogenic use of steroid. When the steroids has been used inappropriately for a longer period of time, whenever they are stopped suddenly, patient will develop adrenal insufficiency. So that is the most common cause. The second most common cause for primary adrenal insufficiency is the infection. Tuberculosis, histoplasmosis are the common infection which cause the primary adrenal insufficiency. Other includes adrenal hemorrhage, adrenal autoimmune conditions which can have primary adrenal insufficiency. So basically, when patient land up in the ICU with the adrenal insufficiency, either patient is having a chronic adrenal insufficiency, patient is maintaining okay with that partial cortisol deficiency, and whenever patient develops any critical illness, patient develops some infection, or patient has myocardial infarction, stroke, or even patient has been started on some medication, like patient is having tubercular adrenal insufficiency, patient is having maintaining cortisol level, but when patient is started on ATT, because of ATT there is an increased metabolism of cortisol, and patient will end up with adrenal insufficiency. So patient is having chronic adrenal insufficiency with superimposed some condition which leads to the acute adrenal crisis. Another condition in which patient develops acute adrenal insufficiency, like in patients who are having adrenal hemorrhage, patient is having infection, meningococcal infection, Waterhouse-Friderichsen syndrome, patient has developed acute adrenal hemorrhage, patient who are on anticoagulants, patient can develop acute adrenal hemorrhage and present with the acute adrenal insufficiency in the ICU. And the third condition is the critical illness related cortisol insufficiency. So let us talk about the most common cause, the iatrogenic adrenal insufficiency. The HPXS suppression depends on which kind of steroids has been used, which type of steroid, the duration of treatment, the timing of dosage, route of administration. Multiple factors will be there which suggests that the exogenous steroid, how much it will suppress the HPXS. Overall, a daily oral dose of more than 30 milligram of hydrocortisone, more than 7.5 milligram of prednisolone, or more than 0.75 milligram of dexamethasone, more than 3-week duration, patient will be having HPXS suppression. In any case, if patient is using this kind of steroid, it should be tapered off slowly rather than discontinuing rapidly. 2 slides about the critical illness related cortisol insufficiency. There is a multiple factors which leads to the cortisol deficiency in the critical illness, starting from the cortisol synthesis, metabolism, the binding proteins. There are a few risk factors like exogenous steroids, opioid use, some medications like etomidate, rifampicin, phenytoin, which increase the cortisol metabolism, which all causes the critical illness related cortisol insufficiency. And how it will be manifested in the ICU, Patient will be having unexplained encephalopathy, delirium, fatigue, unexplained requirement of the vasopressor. Patient will not go off the vasopressor support, the electrolyte disturbances, as well as the new onset eosinophilia. In this kind of condition, we can suspect that patient might be having cortisol insufficiency related to critical illness. And this is how we diagnose. There is adrenal crisis. There is very clear-cut diagnostic criteria which I have already discussed. It can be divided either whether patient is having primary or the secondary adrenal insufficiency. Patient should be started on steroid replacement, gradually tapered off to the maintenance dose. Another thing is the critical illness related corticosteroid insufficiency. Again, there are no definitive guidelines to diagnose this condition. However, a low cortisol level with low ACTH, it confirms that patient is having critical illness related cortisol insufficiency. Patient should be started on corticosteroid replacement. Patient, after initial improvement, patient should be re-evaluated after 5 to 7 days to see that patient HP axis has been recovered or not. How to manage this patient? So we don't wait for the laboratory results, especially when we are suspecting very strongly the adrenal insufficiency. Patient should be started with the IV fluids, obviously with signs of fluid overload, and the hydrocortisone should be started 100 milligrams state, followed by every 6 hourly, and depending on patient clinical condition, it should be tapered, and all the supportive measures should be continued as needed. The mineralocorticoid supplementation will required if patient is having primary adrenal insufficiency. However, till the hydrocortisone dose is 50 milligram per day, patient will be not requiring mineralocorticoid supplement, because hydrocortisone will be having both glucocorticoid as well as the mineralocorticoid activity. However, if you are using prednisolone, methylprednisolone or dexamethasone, patient will be required fludrocortisone supplementation also. After stabilization, it should be gradually tapered off. What should be the best regime and how to monitor? Again, for the glucocorticoid, the best steroid to give in a maintenance dose is the oral hydrocortisone. It is the most physiological with the least side effect, the 15 to 25 milligram, and it should be monitored on a clinical basis. For mineralocorticoid supplementation will be required in patients who are having primary adrenal insufficiency, and the dose is 0.05 to 0.2 milligram once daily. It should be used very cautiously in elderly patients who are hypertensive, who have low ejection fraction because of the risk of fluid overload. Androgen replacement is still a debatable topic, and it may require in female patients who are having primary adrenal insufficiency. The additional explanation to the patient that the sick day rule should be explained to the patient, that any illness when you are having and you are adrenal insufficiency, you are having adrenal insufficiency, you need to increase the dose of steroid. During minor illness, even a severe illness will require a shot of hydrocortisone. Even perioperatively, patient will require additional dose of steroid, and that should be explained to the patient. How long steroid needs to be continued? If the underlying condition is irreversible, it needs to be continued for lifelong. But in cases like when patient is on exogenous steroid, the HP axis will recover over a period of 6 months to 1 year, and later on we can stop steroid. But how we can stop the steroid? We need to gradually taper off. We need to see that patient HP axis has recovered or not by doing ACTH stimulation test, and later on we can stop the steroids. Thank you.